Sir, you are in live. Good to go.
Okay. So good afternoon, ladies and gentlemen. Welcome to this specially important webinar on management of migraine recent advances. Now you know that this has been the migraine month and the migraine week that has followed, and we had a series of webinars on migraine or headache disorders. So this is the third in order, and we have a very distinguished faculty for today's meeting, and we have designed the meeting in such a way that it will be not only useful for you to understand the migraine, the nuances of migraine, and also to get some real experience from the real life cases and how to manage them. What are the difficulties that you face? What are the challenges that you face? So I think this webinar will be a very interesting and important one for all of us. So we have in my distinguished panel today, Dr. Tapas Kumar Banerjee. He will take on the first lecture. He is the director and the chief consultant neurologist at the National Neurosciences Center in Calcutta. And he's a very well-known neurologist in the country, and he has got multiple awards, and he has got a lot of work done in the fields of demanding disorders, headaches, and epilepsy. So he will be speaking on the challenges in the migraine diagnosis. Now you see that migraine diagnosis can be very easy, because the symptoms will just be over you cannot miss them. But then there are lots of patients where the diagnosis may become even more challenging because of the subtle variations in the theme. The phenotypes may change. The other elements might actually camouflage the symptoms. So there are a lot of challenges that we see in day-to-day practice. So Dr. Banerjee is going to talk about that. Now, before we start and before I invite him for the talk, I request everybody to put up your questions in the chat box, and I will try to take it up after his lecture to each of the faculty, and then we can have a very fruitful discussion about it, because webinar, we are distant, it's a digital medium, you are sitting somewhere else, we are sitting somewhere else. So in order to be actually connecting together would be through questions. So put up your questions and I'll take them up as far as possible during this webinar. So may I invite Dr. Tapas Banerjee to start his first talk on the challenges in migraine diagnosis. Dr. Banerjee, can you share your slides, please?
I think it is visible. Is it visible?
Yes.
Yeah. Okay. Thank you. Good evening, everybody. And the task for me is to talk on the challenges in migraine diagnosis. Before I proceed further, I would like to thank Professor Debashish Choudhury for his very kind invite. Migraine, as you all know, is an extremely common disease. It ranks the third most prevalent disorder and seventh highest specific cause of disability worldwide. There are two major types of migraine without aura and migraine with aura. The diagnostic criteria is very well known to you. The migraine without aura has headache lasting for 4 to 72 hours if left untreated or unsuccessfully treated. The headache will have at least two of the four characteristics: unilateral location, pulsatile quality, moderate to severe pain intensity, aggravation by routine activities. The headache should have at least one of the accompanying entities: nausea and vomiting, photophobia, and phonophobia. Now, the diagnostic criteria of migraine with aura, they have all the criteria for migraine without aura, plus at least two attacks should fulfill criteria number 2 and criteria number 3. And criteria number 2 says one or more of the following fully reversible aura symptom will be there. It could be visual aura with flashing lights, sensory aura, speech aura, motor aura with weakness of one side, brainstem or retinal aura. And at least 3 of the following 6 characteristics of the aura will be there. At least one aura should be spreading over more than 5 minutes, 2 or more aura occurring in succession, each aura lasting from 5 to 60 minutes. At least one aura is unilateral, at least one aura symptom is positive, and aura accompanied or followed within 60 minutes by headache. So this is a definition which was there in Cephalalgia 2018. But for the last 3 decades, for the last 30 years, the diagnostic criteria of migraine with and without aura has been more or less same. So once you see a patient of migraine and take a careful history, and if they fulfill the criteria of diagnostic criteria of migraine, it's not very difficult to really uh, diagnose it. But there are occasions where migraine diagnosis may be challenging and you might end up in a diagnostic conundrum. So why I will tell you that? Migraine headache, they say one of the criteria is the headache is unilateral. There's a pulsating quality, it's moderate to severe. But the migraine headache may be bilateral or vary during a single headache. It may be mild and it may not be pulsatile. It may be a continuous headache in contrast to the episodic headache, which is classical definition of migraine. And the headache duration may last for less than 4 hours to over 72 hours. There may not be having any accompanying problem like nausea, vomiting, or photophobia, phonophobia. There may be aura without accompanying or following headache, and there may be interictal hypersensitivity. In between the headache attacks, the patient will have tenderness of the scalp, which might have to, you have to distinguish other more serious disorder if it happens in an elderly person. There may be certain migraine variants. As you know, migraine starts off at least with the episodic headache. The patient may start off initially as a daily or near daily headache without having any preceding episodic migrainous headache. And this daily or near daily headache may be a feature of migraine and it may occur even without analgesic overuse. Now, I speak headache is a very distinct entity, which is endomethacin responsive. But 40% of migraineurs may have isolated brief stabbing pain in the orbital temporal parietal area, which is similar to that of I speak headache, but this is a manifestation of migraine. And this sort of problems, you only reassure the patient or you can treat with certain prophylaxis like amitriptyline, etc. Thunderclap headache always indicates a very sinister underlying cause like subarachnoid hemorrhage, dissection, or if it can be venous sinus thrombosis. All those various list of very serious problems may be there if the patient has a thunderclap headache, where the pain reaches its maximum intensity within the first 60 seconds. But if you sort of exclude all the other differentials from the investigations, it can occur in a migraine sufferer occasionally, what we call as crash migraine. Now, there may be alternative diagnoses that could be mistaken as migraine or what we say migraine mimics. For example, cluster headache. You know, cluster headache is a very clearly defined headache phenomenon, but many patients with cluster headache at other times, they can have headache which is very similar to migraine with or without aura. And if this sort of thing happens, that this is a cluster headache variant, we call it cluster migraine. So here, cluster headache can be a migraine mimic. Similarly, hemicrania continua, we know this is a unilateral, very continuous headache, which may have sometimes a migrainous type of attacks at times. Initially, it might be episodic for a short period of time, and you can have hemicrania continua, which can be a migraine mimic. 52% were misdiagnosed with migraine and 40% met migraine criteria during hemicrania continua exacerbations. Then there is another entity called new daily persistent headache. Now, this is a very interesting entity where right from the beginning, patients have a daily pain, which is very difficult to treat sometimes, and the pain is continuous all this throughout the day, and it may continue for over 3 months. So this can be another migraine mimic. Then there is a secondary migraine. You know, migraine is a primary headache disorder. There is no underlying pathology in it. But there are certain causes, very rarely, if there is structural lesion in the brain or there is inflammatory disease in the brain, then it can present as a migrainous headache. And this we call secondary migraine. For example, intracranial space occupying lesion. The characteristic headache, they say, is an early morning headache. When the patients get up in the morning with nausea or vomiting, this is a manifestation of raised intracranial pressure. But in migraine sufferers, sometimes they have the manifestations where the migraine features become more frequent and more intense. And that happens in intracranial space organ lesion before they can have any lateralizing neurodeficit or other sort of neurological deficiency. So we always say, whenever you find a patient with headache, encounter for the first time at least, you do a fundoscopy to exclude papillary. It might give you a clue that you have to explore further. Accelerated hypertension can be a migraine mimic. At least on the first sitting, BP checkup is essential for all patients presenting with headache. Acute glaucoma is a very important and very serious disease you have to exclude. If you have a blurred vision, visual loss, halos around objects, redness of the eyes, then this gives a clue that this is eye pathology, and acute closed-angle glaucoma has to be excluded. Acute stroke, intracerebral hemorrhage, cerebral venous thrombosis can present with headache mimicking migraine. Temporal arteritis in elderly persons who are above the age of 60, they may have scalp tenderness, and scalp tenderness, can be a central sensitization effect of a chronic migraine. So you have to exclude if the headache comes at a later phase of life, that am I dealing with a case of temporal arteritis? You have other ancillary features sometimes like jaw colorication, wet loss. So this is also a migraine mimic. Then carotid artery dissection, you may get pain in the head, and also there is neck pain. If the Horner syndrome is also there, that gives us a clue that it may be carotid artery dissection. Chronic meningitis, sometimes many of us have seen cases of tuberculous chronic meningitis. They present with headache. They don't have, fever coming on. They don't have other features. They don't have the nuchal rigidity or chronic sign. The headache may be one of the presenting feature, which is persistent, refractory to usual therapy. So if the headache is persistent, refractory to therapy, CSF analysis is warranted in that case. Reversible cerebral vasospastic syndrome, recurrent thunderclap headache is a classical kind of presentation, but these can be migraine mimics at times, so as unruptured AVM, angiopathy, dental pathology. Now come to certain disorders where migraine maybe there is an underlying diagnosis, but they present as some other disease, what we call chameleons. For example, transient ischemic attack or stroke can be a chameleon. The migraine patient presents like a stroke, or they may present like epilepsy, or peripheral vertigo, transient acute confusional state, psychiatric illness, radiculopathy or myofascial pain syndrome. I'll take one by one. Now, if somebody comes with unilateral or bilateral visual loss, hemi-filled visual loss, unilateral numbness or weakness, in a person who is an arteriopath, at a little bit elderly age group patient, this is how a stroke commonly presents. But in a migraine sufferer, it could be an aura of migraine. The way to really differentiate, you have to know the background story of the person. What kind of person is that, whether it's an arteriopath, a little bit elderly, or whether he is a chronic sufferer of migraine. Then in migraine aura comes actually a little bit more slowly. It comes slowly, it then gradually reaches its peak, spreads slowly, and then it wanes off slowly. But a stroke is a stroke. It presents very abruptly, presents acutely to its peak, and then becomes static. So that is how we have to distinguish. Stroke can be a presenting feature of migraine. But if you see a sudden onset, brief duration for seconds, this is a transient ischemic attack. This is a pointer against migraine aura. That doesn't come so suddenly and disappear so abruptly. Epilepsy, temporal lobe epilepsy can present with olfactory or gustatory hallucination, but rarely it can be the way a migraine aura can present. The clue is in migraine aura, the onset is slower and the duration is much more prolonged. Another very important thing to distinguish is occipital epileptic seizures from the visual aura of migraine. And there are certain distinguishing features between the two. Occipital epilepsy and migraine aura both can present with flashing lights in front of the eyes. In occipital epilepsy, this flashing lasts for less than 3 minutes, whereas migraine aura can linger on from 5 to 30 minutes. Occipital epilepsy, the onset is rapid and the offset is also rapid. But migraine is a very gradual onset, gradual spread, and the offset is also gradual. Another pointer is that the migraine aura looks like zigzag lines, linear fortification spectra, and black and white in color. But occipital epilepsy has a beautiful sort of circular, multicolored visual presentations that one can see. So these are the distinguishing features one has to be aware of to differentiate between the two conditions, occipital epileptic seizure and the migrainous or visual aura. Another chameleon is peripheral vertigo. Now, in many patients, vestibular neuritis, acute attack of sort of vertigo, it can happen in vestibular neuritis, or benign paroxysmal position vertigo, transient vertigo when they turn the position of the head. But if somebody is a migraine sufferer, vestibular migraine, acute onset vertigo, with or during other times the headache is not there, may be the presenting feature. So one has to be very aware of this fact that whether they're dealing with a vestibular neuritis or a vestibular migraine. Because if you think this is a vestibular migraine, migraine prophylaxis can be very effective treatment for this. In that context, there's a point to note that in children, sometimes present with benign paroxysmal vertigo. And this can be one of the recognized precursor syndrome of migraine. Then there is transient acute confusional attack. Transient mild clouding or confusional state with or without headache may be one of the way of presenting in children with migraine. And this is called acute confusional migraine. It occurs in 0.5 to about 8% of children who are migraine sufferers. Rarely it can even occur in adults or adolescents. For the transient acute confusional states, we have to have so many other differentials. Could be epilepsy, temporal lobe epilepsy, or it could be in arteriopath, something like a TIA has occurred. But you have to have a careful history with a patient being a known migraine sufferer, where we can see this sort of presentation can happen. Then migraine patients can have these complex visual hallucinations where they have what we call Alice in Wonderland syndrome. They can see the hallucination, the objects in front of them were growing up in size, larger in size, or very small in size. Micropsia or micropsia are the things. But these sort of things quite often happens in a psychogenic individual. So psychogenic psychogenicity can be one of the chameleon of migraine. Myofascial pain syndrome with aches and pains on one side of the body, with or without radiculopathy. This pain in upper and lower limb can occur also during an attack of migraine. And this can be one of the migraine limb pain, what they call it. It spreads gradually over 20 minutes or more and is ipsilateral to the side of the headache. Then there are a lot of other chameleons, the gastrointestinal disease, cyclical vomiting in children, multiple sclerosis or neuropathy can be a presenting like thing which is a feature of migraine underlying because they have pins and needles, paresthesia in the hands and feet. Coronary artery disease or syncope can be the presenting feature very rarely of migraine. Then we have conditions that can lie between migraine and other diagnoses, which we call borderland. Borderlands are entities which are not really coming into the classical picture of one disease like migraine, nor it is falling into a classical picture of other disease like stroke or epilepsy. So it is something, it is sitting on the fringes of all these diseases. Now, this borderland word is derived from the very famous book by Sir William Gowers, by Sir William Gowers, who is a very famous epileptologist and neurologist. He wrote this book, Borderland of Epilepsy. And from there, we have so many other borderlands now, borderland of stroke, borderland of migraine. So these outliers, so what are the outliers of migraine? Migralepsy is one of the outliers. Migralepsy by definition, which was given in ICHD 3, is a seizure triggered by an attack of migraine with aura. Epileptic seizures arise during or within 1 hour of migraine with aura attack. It's called migralepsy. It's a very rare entity that occurs. And where do you want to really put it? Whether you put it in migraine, whether you put it in epilepsy. It is sort of in between entity. And there's migrainous infarction. By definition, one or more migraine aura symptoms occurring in association with an ischemic brain lesion in the appropriate territory, demonstrated by neuroimaging, with onset during the course of a typical migraine with aura attack. So migraine, aura, and then they have this stroke. Where would you like to put it? So these are the borderlands. Then there's another interesting phenomenon, the transient global amnesia. Now there are 4 categories of transient global amnesia. The transient epileptic amnesia is very clearly distinguishable. It happens in temporal lobe epilepsy. It lasts for less than 1 hour. And if you have an EEG, the EEG will prove that this is an epileptic amnesia. That is not very difficult. The differentiation comes between vascular transient global amnesia and migrainous transient global amnesia. Because in both cases, the duration is much longer. It is almost 2 to 24 hours in duration. Now, if somebody is a vasculopath and they have this global amnesia where, the patient suddenly cannot recall what has happened in the past few hours. Suddenly they forget everything, and then when they remember, they don't know what they did over this period of time. So that can happen in somebody who is a vasculopath or somebody who is a migrainous individual. So we have to take a careful history before we can say in which category you would try to keep it. Psychogenic amnesia, of course, it has a variable amnesia of a variable duration in somebody who's personality disorder. So it is not that difficult. So this transient global amnesia, migrainous, where do you want to keep it? So it is in the borderland. So these are all those perplexing problems that can arise in the diagnosis of migraine. So I'll just illustrate it by showing you 2 very quick cases. Case number 1 is a 50-year-old man who presented with recurrent acute onset throbbing bitemporal headache. And during the headache, sometimes he had this right-sided homonymous hemianopsia with flashing lights. Duration, he was not very sure of the duration. Said it lasting around 5 minutes or so, occurring 4 to 5 times a day. And many a times after this event of flashing lights, he's having this acute migrainous headache. Occasionally, he was telling he was having complex visual hallucination. At times he said that he's seeing 2 kids playing Ludo. That sort of formed visual hallucinations happening. Patient was tried on various migraine prophylactic drugs with beta blockers of flunarizine of no effect. Then once he had a generalized tonic-clonic convulsion. And then he had some drop at the intermittent transient loss of consciousness. His investigation were normal, including cerebral MRI, MR angiography, and 1 episode was witnessed by us. He suddenly became unresponsive, and we noticed he had a conjugate horizontal jerky eye movements to the right. Soon after he regained consciousness, we subjected him to automated perimetry, and he has shown left homonymous hemianopsia. We did an EEG on him. There's an old EEG graph, and you can see he had a left occipital spike discharges. So this is he was treated with phenytoin topiramate, no further seizure, no further headache. So these are localization epilepsy with ictal or postictal headache. So this is one of the migraine mimic the patient is having. Another case, the 43-year-old non-hypertensive, non-diabetic man. From the age of 10 years, he had this left episodic hemicranial headache with the accompanying photophobia, phonophobia, etc. 14 years of age, during the time of headache, he developed transient left third cranial nerve palsy with pupillary involvement. Then he was treated elsewhere, and the doctors were noticed that once he was given oral steroid, the headache disappeared and the ophthalmoplegia disappeared. Then for the first few years before the patient presented to us, he had He was taking oral steroids on a daily basis because he said that is the only way he could control his pain, but his ophthalmoplegia remained persistent for the last few years. He had a pupillary involved ophthalmoplegia. When you do the MR scan, he was found to have a small round swell of 6 millimeter in diameter in the supracellular cistern along the cisternal portion of left third cranial nerve, which was hypointense in T1, T2, and a post-contrast study showed enhancement. And you can see this is a T2 shows a hypointense nodule here. And when you did a contrast, it has taken a heterogeneous enhancement of the contrast on one side at the exit point of the third cranial nerve. So you had a third cranial neuropathy with ophthalmoplegic migraine. Also, these are migraine mimic. The differentials will also be there in that. That also Hun, schwannoma, hemangiometastasis, aneurysm. So I conclude here, migraine easily can be diagnosed in most of the cases if you apply the ICH2 criteria, but there are occasions where migraine can be a diagnostic conundrum. We have to investigate them thoroughly with various investigative tools to establish the proper diagnosis. Thank you very much.
Thank you, Dr. Banerjee, for tackling a very, very complex subject in a very, very lucid and comprehensive manner. So you have talked about the mimics and you have talked about the chameleons. And obviously in clinical practice, we not only see the typical classical cases of migraine, but we also see these cases, and at times it becomes very challenging for the diagnosis. So there are a few questions here. So first question I'll ask you only. The question is, how do you differentiate migraine from sinusitis headaches when there is no aura?
Right. Actually, if you look at the International Headache Society classification or definitions, which has been there from 1988, they mention very categorically that chronic sinusitis is not a cause of headache. You can get something like acute sinus headache. An acute sinus headache has certain features. It can occur in the sinus region, frontal or maxillary, and you can have the congestion with real discharges from the nose. So that's an acute sinus headache. But the chronic sinusitis, if you see on the X-ray, chronic sinusitis, that that cannot be a cause of headache. I guess those are mostly migrainous headaches.
Okay. So yeah, there has been some studies also, the people have started estimating in a given population the possible number of migraine based on the general epidemiology. And they could find that the number actually reported is much less. So where are these patients going? Actually, they found out these patients are going mostly to the ENT specialist and labeled as sinusitis. And later on, when these people were identified and given the drugs, anti-migraine drugs, they became better. So definitely, it's a common problem. The people going for sinusitis, diagnosis, cervical pain is cervical spondylosis. In women, premenstrual syndromes, and because the migraine gets accentuated or been precipitated by menstrual cycle, so they go to the gynecologist and labeled as a premenstrual syndrome or menstrual irregularity syndromes. And so therefore, these are the things which you need to bother. And of course, the ophthalmologist. The first thing the people with migraine will go to a doctor and say that, well, kindly check my specs, or do I need some specs, So these are the common things we have been seeing for the last 30, 40 years. And we have been trying to educate that no, if there is a recurrent pattern of self-limiting headaches, which is a long duration with systemic features like nausea, vomiting, photophobia, phonophobia, and makes you sick, you cannot move, you have to lie down. So therefore, that is basically a migraine. So you need to diagnose that. Of course, you need to rule out secondary causes if there are some red flags. The second question is to Dr. Ravi Shankar. That this question is very interesting. What is the gravest complication of migraine?
Right. Is it for me or Dr. Ravi Shankar?
Dr. Ravi Shankar.
Yeah.
Unmute yourself, sir.
Can I add a point about the earlier question also, Debashish, before I go on?
Yes, sure.
Please.
Sure.
There are a couple of situations where, as Tapas has rightly pointed out, it's the acute one which we have to consider. But we have to remember that when there is chronic headache, sphenoid sinusitis is a hidden area. People do not tend to diagnose the rhinogenic causes of headache like a contact point headache and other situations, everybody thinks that it's only the sinusitis which is the be all and the end all of the ENT domain of headache. So there are many chronic headaches where rhinogenic headaches can be a cause. And we have had one or two patients who had definitely well-established migraine. On top of that, they developed acute sinusitis and were treated as an acute attack of migraine till a CT scan showed up that it was a coexisting sinus infection. And lastly, the persisting habit still of people going in for a plain X-ray tends to underdiagnose the rhinogenic causes of chronic headache. So it has always to be a CT-PNS rather than just a plain X-ray. So now to come to your question, Devashish, what is the most dangerous complication?
What is the gravest complication of migraine?
The gravest complication, yeah, in my opinion, the gravest complication of migraine would be one is a migrainous infarction. Two is episodic migraine going on to become chronic and refractory because of medication overuse headache and patient not responding to do what you may. That leads to a lot of disability, and that can be a grave situation to treat. And ophthalmoplegic migraine, the case which was shown by Tapas, sometimes does not respond to steroids. And then it can be a very difficult thing. In addition, there can be many things I might have forgotten, but these are the three which come to my mind as important complications.
Right. And sometimes, although Dr. Banerjee has said about the crash migraine, which is, disputed by many people about, whether the thunderclap headache kind of situation happens in migraine or not. And some people believe that there is always a cause of, anything very, very severe thunderclap presentation of migraine should always be investigated. And sometimes, even in migraine patients, if such pain happens, then you need to investigate. And sometimes aneurysm or some other RCBS, they might also be life-threatening at times. So those need to be looked into. So next question is to Dr. Sanjay Prakash. The question is this, that can we label the first attack of severe headache as migraine, or we need to work up? For example, the patient presenting with crash migraine.
No, definitely not. If you go according to the criteria, definitely with migrainous aura, we need at least 2 attacks. And for migraine without aura, at least 5 attacks. So ICSD have defined some criteria, just considering that up to 4 or attack, maybe there may be chance of secondary headaches. So for migraine without aura, you need at least 5 attacks. It means up to 3 to 4 attacks, you need to investigate to find out the any cause. So in the first attack, I will not label actually in any primary headache, I will not have a first attack as a primary headache disorder. So we need investigation.
So that is very, very important. They don't give a level on the first attack unless the patient comes to you and tells you again that what happens. And many times you need to investigate the first attack. So that is very important. Next question is to Dr. Thomas Matthew, that how will you distinguish between an occipital syndrome and a migraine? Because the neck pains can also happen in migraine.
Occipital syndrome, what they mean? Is it a pain in the occipital region?
No, probably an occipital neuralgia, probably.
I think, I don't know what
occipital syndrome and cervical neuralgia. Like, okay. Neck pain in the migraine, some posterior dominant migraine where there is a lot of neck pain versus a cervical or occipital neuralgia.
Yeah, neuralgiform pains are usually brief. Migraine by definition should be untreated and unsuccessfully treated should be 4 to 72 hours. Maybe neuralgiforms are more brief and more recurrence occurs in a day, while migraine usually you get a single attack and it is longer. But I feel the person was asking maybe you have only pain in the occipital region or neck pain, whether you will be able to diagnose migraine or not. I don't know whether, or a cervicogenic headache due to some disc or something like that.
Yeah.
But many migraineurs have a neck pain as a part of their component, and that it is a part of the migraine. And musculoskeletal pains are very common with migraineurs. They have pain in the neck, they have pain in the back. So pain syndrome, it's a chronic pain syndrome. and they have a lot of pains in different areas. And in a few of our studies, we have found fibromyalgias are very common in patients with migraine, and the reverse also. Patients with fibromyalgias you take, many times they tell about fibromyalgia, and when you ask about migraine, they have migraine. So this musculoskeletal pains can be part of migraine, can be part of tension type headache, can be cervicogenic. And most important thing is to stick to the criteria. All the primary headache disorders stick to the criteria. See, as Sanjay has told, you have frequent attacks. So the main, they have a pattern and they have a pain-free periods. And then 2 of the following 4. So that is very important. Either unilateral, pulsating quality, moderate to severe in intensity, and avoidance of routine physical activity or worsening of physical activity. 2 of 4, and then you fit 4 to 72 hours. And then you have that 5 attacks. For migraine with aura, 2 attacks. And then one of the following, either nausea or vomiting, either one of them. But you should have both photophobia and phonophobia. So either one of them. So if fit this much, I think we can safely diagnose migraine. And as the previous questions were sinusitis, rarely you do have a pattern. When you don't take food, and if you get a headache, it is not sinusitis, it is migraine. So just see the precipitating and provocating factors. You travel and you get a headache. It is very unlikely. Every week you travel and you get a Sunday headache. It is not sinusitis. Yes, sir. Sorry, sir.
Okay, right. So I think that has been answered. Now there's one question for Dr. Amit that is asking that what is the migraine and epilepsy? You know, do you consider then the migraine is happening as a manifestation of epilepsy in some part of the brain, or migraine, could it be just a pre-ictal phenomena?
Migraine, especially migraine with aura, there is cortical spreading depression, and in epilepsy there is specific discharges in the brain which can be detected in EEG. So both the phenomena are different. So migraine is a different entity and epilepsy is a different entity, and sometimes they are occurring together, then it is called as migraine epilepsy. So we should distinguish these 2 entities identically.
Right. So I think, you know, currently, in fact, migralepsy term is not that much in use. Actually, ICSD does not advocate the use of the term migralepsy. They are migraine triggered seizures. That is the term actually they are using. So that's very rare in my view. And I think Dr. Ravi Shankar is also going to concur with that, you know, true migraine triggered seizures are difficult. And like one case, Dr. Tapas showed, maybe that, yes, those cases, but they are very, very uncommon. Most commonly, what you will find is a clinical situation where a particular visual symptomatology patient may come to you, and you might have difficulty in identifying that whether this is migraine aura or it is an epileptic aura. So that actual distinction becomes a little problematic at times. So there's another question for Dr. Ravi Shankar that, you know, how do you distinguish in a migraine patient a tension type headache? Can they occur together, or you know, or they may be, because tension type headache can also be bilateral. So what is how do you differentiate them?
Yes, this can be a difficult point to differentiate. When it is occurring separately, it is not difficult because tension type headache is a featureless headache. But when the migraine becomes a little more chronic and tends to lose its migrainous features and develop features more of tension type headache, what is called as chronic migraine, or what used to be called chronic daily headache, you will find it more difficult to differentiate between tension type headache and migraine. But by and large, most of the, except mild migraine always has accompanying features, and it is not difficult, and tension type headache rarely presents to the clinic. It's more often the disability which decides the difference between migraine and tension type headache. So any disabling recurrent triggered headache is migraine. There are very few percentage where you need to treat with a little amitriptyline and then see whether you are differentiating between tension type headache or migraine. But by and large, it is not very difficult. It's only when it becomes chronic that you have difficulty.
Correct. Correct. Now, this is for Dr. Banerjee. Again, on a similar type of question, can a migraine patient present as cervical radiculopathy in the wing woman? Most of the times classical L5, C5, C6 radiculopathy, but MRI, NCS are absolutely normal, but the patients have pain, so they cannot even lift the arm during the episode. So in effect, he is asking that whether, migraine patients can present with a sensory aura type of symptoms in which there might be a presentation like a cervical radiculopathy.
Yeah, well, I mean, we know about this migraine limb pain. Arm or leg can be in the ipsilateral, the location where the headache is, the same location they can have limb pain, which again I have said it spreads. It spreads over a few minutes, quite a few minutes, because that's how the aura presents. So that can present, but by and large, most of them you see the migraine headache. It's not only the headache, one can get severe neck pain with this sort of with migraine. So neck or head pain is one of the, some people may have only neck pain, but not the head pain. That can also be a presenting feature of migraine. But on the other side, migraine patients can also suffer from fibromyalgia, myofascial pain syndrome. So a lot of pain in the limbs, in the upper limbs, cervical myofascial pain syndrome, which is a common comorbidity with migraine. That can also be there.
Okay, so this question again for Sanjay, like can migraine pain be bilateral? And in that case, how to differentiate from other headaches?
Yeah, definitely. Migraine 40 to 60% study have shown that migraine patient may have bilateral headache. So bilaterality doesn't rule out migraine. Tension type headache most likely will have bilateral headache, but migraine patient will have bilateral headache. You need other feature. Other features may help you in differentiating migraine. Throbbing pain, nausea and vomiting, very important feature, photophobia and phonophobia. And the most important, I think, is the severity. More severe attack, and it will get aggravated by some work. So just by one feature you cannot rule out. At far as ICSD is concerned, they have mentioned 4 criteria, only 2 should be present. So unilateral headache is not a must for the migraine. Bilateral possible, and actually in 40 to 60% patient will have bilateral headache, a holocephalic, you can say.
Okay, right. So bilateral headache, in fact, in India, I mean, our studies show that about 60% of the patient will actually have bilateral headache, and 40%. In the West, they said 40% bilateral and 60% unilateral. So, the figures are like that. So basically, bilateral headaches are not uncommon. They're, in fact, equally common as a hemicranial headache. Although characteristically, migraine headaches are hemicranial to start with, but it can happen bilateral. So that nothing prevents you from diagnosing migraine.
I'd like to add one point here.
Right.
One of the important differential diagnoses of migraine could be a hemicrania continua. As Dr. Tapas' slide has demonstrated, 50% patient, 52% patient of hemicrania continua are diagnosed as a migraine. So it is very important to differentiate migraine, especially side-locked migraine. If it is always one side migraine, then you become very cautious that it could be something else, because side-locked migraine is not that rare. Side shifting could be. So side lock, you need to differentiate with hemicrania continua, because hemicrania continua patient may have migrainous feature, attack maybe for whole days, just like a migraine.
Right. Okay. So Thomas, this is a very short answer you give. That tell us something about the scales to assess the severity of headaches. What are the scales that you use to assess the severity of headache? Migraine, especially
migraine disability score, where you ask particular questions, how many days you could not work, school off, work schedule, like that. You have a migraine disability score which you have to just fill and get an answer. But for a practical purposes, what we do is to have a simple headache diary where you put the date of the headache, then you put the start and stop time, and then you tell the patient to have a visual analog score or an intensity of headache, 10 out of 10 how much. So this will be a simple scale which you can use in a routine clinical practice. If you're doing a research study, you can go for the MIDA score, the migraine disability score. But for practical purposes, you need to have a simple Excel sheet where you have the date, which will give the frequency of your headache. You put a start time and a stop time, which will see the duration of your headache. And then you score on the intensity, so you know the intensity of the headache. And then you can have another 2 columns where you can put a trigger and the medication you use and relief. So that will get an idea of the number of analgesics you take. And the triggers will get an idea how to modify the lifestyle. And this is very important. Yeah, sir.
Okay, right. Thank you. And now last question quickly to Amit is this, that, when there is a first severe acute catastrophic migraine, that needs to be investigated, even if triggered with typical features?
So,
The first catastrophic headache in a migraine patient with the typical features, but it is a catastrophic headache. So that needs to be investigated, or do you just pass it on as a migraine?
sir, if the onset of the headache is within seconds, if that specific headache is within second, and it categorized in the category of thunderclap headache, and along with any red flags are associated with this headache, then we have to do workup for the other headaches, and then we first have to rule out other things, and then only we can categorize it as a migraine headache.
Correct. So any thunderclap presentation of even in a non-migraine patient would necessitate the same protocol as you apply for other patients, even if the features are typical, because migraine can, as Dr. Tapas showed, that mimic a lot of other types of secondary headaches also. So we go to the next lecture and we take up the questions subsequently. Dr. Ravishankar, from the housekeeping, there is a request to you that probably you are logged on 2 devices or something like that. So you kindly switch off one device, they're saying, so that, So I'll start sharing. You kindly put off your microphones off so that we proceed with the lecture. Okay. So now let us talk a little bit about, the pathophysiology of migraine, because the next lecture by Dr. Ravishankar is going to be on the management. And I already seen that there are some questions on management. So although pathophysiology of migraine is very, very complex, so I would like to be simple, and I would like to be, take you along the course, because it's a complex topic. So I know that it involves a lot of basic neurosciences, but still I'll try to take you along the course of your understanding of migraine pathophysiology. So people, there's a famous quote by the British British Prime Minister that talking about something else is a riddle wrapped in a mystery inside an enigma. So migraine pathophysiology is also, as Churchill said, that's a riddle wrapped in a mystery and inside an enigma. So we all have known this, that it is an idiopathic recurring headache disorder, which are long-lasting headaches. Typical characteristics are unilateral location, pulsatile quality, moderate to severe intensity, aggravated by routine physical activity, and associated with nausea, photo, and phonophobia. So this is the definition given by ICHD. But I see migraine more as a syndrome, constellation of signs and symptoms. You have a pre-headache phase which are called premonitory symptoms. You have mood changes, fatigue, cognitive changes, muscle pain, food craving. And then in about 30% patients, you have 25 to 30%. In India, it is less, to the word about 10 to 15% patients. You will have this fully reversible neurological changes, visual, somatosensory, which is called aura. So, and then the early phase of headache starts, the dull headache, nasal congestion, some autonomic symptoms, muscle pain, and then there is an advanced headache with the typical features of unilateral throbbing pain, nausea, photophobia, phonophobia, and osmophobia. And even if the headache is gone, there is a stage called postdrome, which consists of fatigue, cognitive changes, and muscle pain. So it's every stage may not be present in each attack or in each patient, but this is a mix of the symptoms complex that you can see in migraine. And more importantly, you see other complex wide-ranging symptoms with migraine, which are not included in a definition. They are the sensory dysmodulation, as was talked about, the fibromyalgias, the muscle pain, the pain in the face and the neck, the cognitive dysfunctions, person is not able to concentrate, not able to do finer tasks, autonomic dysfunctions, nasal congestion, slight amount of tearing, slight amount of rhinorrhea, neck pain, and the change in mood, right, effect. So all these things go on concurrently along with this. So therefore, the migraine is not just headache, it is much more than what meets the eye. So there have been a lot of milestones in understanding the migraine pathophysiology. Now, one was starting from the Harold Wolf, and then we progressed to a lot of important landmarks, including the electrophysiological data, the functional MRI, the genetics. And of course, now we are moving to the neuropeptides, neurotransmitters, and receptors in the era of molecular biology. So this was Harold Wolf. He's actually ruled the headache world for about 40 years. So for him, actually, it was simple that the trigger or the stress will cause the vasoconstriction, There'll be reduced blood flow that will cause the neurological symptoms called the aura. And you have followed by the vasoconstriction. In the second phase, you will have the vascular dilatation. You have distended blood vessels, which will cause the throbbing, and that will cause the pain. So, it was a simple process. But all this actually was basically demythified by this particular study, a magnetic resonance angiography of intracranial and extracranial arteries, which showed that actually the migraine pain was not accompanied by extracranial arterial dilatation, and not only slightly by intracranial dilatation. So actually what people were saying about this throbbing pain was an epiphenomenon and is not directly related to the pathophysiology. So, earlier terms like vascular headache was given up, and the proper term to be used always in these patients as migraine. You should not use a vascular headache. I still see prescriptions by various physicians writing as vascular headache. So there's nothing called vascular headache. Okay. So the first thing is to understand this is very, very important, that migraine brains are having a general neuronal hyperexcitability. So there are various, electrophysiological studies. There are also transcranial magnetic studies that have shown that migraine exhibit a lack of habituation in response to repetitive stimulation in contrast to non-migraine controls during interictal state. So this may be because of increased neural excitability, decreased inhibition, or decreased pre-activation level. But whatever it is, it shows that there is abnormality of the cortical information processing in migraine between the attacks, that is interictal period, and increased responsivity to external stimuli in migraine. That is, the people, now you go to a party, you hear noises, you hear sounds, you see the lights, strobe lights. Now, as a normal person, you will not react to it. Your brain is not going to react, but migraine brains are going to react to it because they have increased responsibility to this external, sensitivity. And this is actually shown by this beautiful experiment. You have got these repeated VEPs, the visual evoked potentials. So in healthy subject, you see that there is the habituation. Actually, you see that whenever in the first train of VEPs, you have got this amplitude this big, and then in the subsequent, on the sixth, by the sixth train of VEPs, you have actually reduced amplitude because there is brain habituates to that recurrent stimuli. But in contrast, in the migraine brain, actually this does initial response is also low, and the habituation doesn't occur during the interictal period. And as you can see that the initial level is also low in migraine patients, both in migraine with aura and migraine without aura. And actually the first epoch, for the first train of VEPs actually determine that what will be the fall or lack of habituation in the subsequent VEP trains. They're showing thereby that pre-activation level is also very important. It shows actually that the migraine brain is hypersensitive, it is hyper-responsive. And in fact, people have suggested that if you combine the VEP and auditory evoked potential, you can actually diagnose, even knowing the history, you put the patient to these two tests, you can diagnose them as migraine because they have a very high sensitivity and specificity. Okay, then came the the era of functional MRI using the BOLD technique and the arterial spill level techniques to know the metabolism and the blood flow. And what they have shown that migraine with aura, without aura, trigeminal neuralgia, and this carpal tunnel syndrome. So in that they have a different patterns of pain network, right? So only in migrainous, you see that there is an increased connectivity within the limbic and the viscerosensory network, thereby showing that this migraine patients have their brains already having a network which is actually defecting in processing. So there is a defect lies in increasing connectivity. So they become hyper responsive. Similarly, in an enhanced pain-inducing activity of the various regions of the brain in episodic migraine has been studied in the Mayo Clinic by the Doddings group. This is the normal pain salience. When when you stimulate your brain by a painful stimuli, by a peripheral or central painful stimuli, you find this kind of a network. So it's called the pain network, right? These areas light up. But if you do that in migraine patients compared to the controls, you see that in certain areas of the brain, they are lighting up compared to a normal control. So that again shows that these brains are not normal in terms of the functionality, and they are very, very predisposed to hyperexcitability. And then more importantly, people have shown that there are certain other aspects of the pain perception like attending to pain and the pain memory. Like, the many migraine patients will come and tell you that, oh, doctor, I don't want to experience that kind of pain again. So there is a pain memory which leaves its trace in the brain, right? And there is a hypersensitivity related to high expectations and hypervigilance for the pain, because people expect that, oh, my next attack might be more severe, it might be more devastating. So there is a heightened expectation and hypervigilance, and this actually alters the pain circuitry in the brain in functional terms, right? So this has also been proven by various studies. So the question comes that you may ask that, well, I understand that it's a hyperexcitable brain, but why are they hyperexcitable? The answer lies in the genetics. Now, migraine is a genetically driven disease, and the major data has come from the certain genetically determined migraine syndromes, like a familial hemiplegic migraine, where they have identified the genes. And I will not go into the details of these genes, but it actually shows that all these are actually related to the excitotoxicity, that glutamate mechanisms, or either they are increased or there is a deficiency of the inhibitory neurotransmitters. So they cause unregulated firing of excitatory neurons, and therefore they lead credence to the idea that this hyperexcitability is essentially because of the mutations at the ionic level, at the channel level, leading to this brain to become hyperexcitable. Now, there is a genome-wide studies in migraine also, and we have so far identified about 40 loci. And what I have found in those loci, they again are basically showing that glutamate neurotransmitter, synaptic development plasticity, ion channels, ion homeostasis, suggesting thereby that the defect lies in causing the brain, or causing this brain to be hypersensitive, to be more responsive to the external stimuli, as we have discussed above. So because of this, we expect that the migraine brains are genetically predisposed. But the next question comes, then okay, fine, these people are moving around, they're doing their work, they are actually very well placed in the society, they are doing both household works or the very top-notch executive work. But why does suddenly this brain homeostasis breaks down in them? They keep on getting these recurrent attacks. So why does this so-called migraine triggers, as we have talked about, the stress, sleep deprivation, sleep changes, or other physiological and emotional changes activate the nociceptive pathways? So for that, we need to understand the first stage of migraine, that is the premonitory stage. Very important data has come up by studying the premonitory symptoms, and it has been found that about 70% of the patients can actually correctly predict the onset of their migraine by the premonitory symptoms. And usually the warning features are difficult in concentration, stiff neck, yawning, feeling tired, feeling weary. So these are very, very characteristic of a migraine premonitory symptoms. And this path-breaking study in which people have been given the migraine was triggered by nitroglycerine, and then they studied the brain activation in the premonitory phase of migraine in this patient, and they found that a lot of areas in the brain are getting activated, but more importantly, the most important structure is the hypothalamus. Hypothalamus is the consistent area which is lighting up in the premonitory phase, even when the headache is not there, before the headache. So the brain is dysfunctional even before the headache. And who is at fault? The hypothalamus. So that is a very important point we should know. So the question is that how does hypothalamus orchestrate these changes? Now, as you know, that hypothalamus is the master, organ for the autonomic control of the body, sympathetic and parasympathetic. So what it does, that dysfunctional changes in migraine brains, they cause an increase through hypothalamus, they cause an increase in parasympathetic tone, and the sympathetic outflow into meninges involving the norepinephrine release. And also there is a secondary action in the form of activation of kappa opioid system. And as you know, the kappa opioid system is in the brainstem, actually is very, very important for the descending pain pathways. So hypothalamus primarily affect the parasympathetic tone of the vessels. So, there are a lot of studies have been done, and they have tried that what happens to these migraine triggers and the hypothalamus. So this is the trigeminal-vascular model of, the migraine pain. So what you have, you have this, sensitive dura, the vessels in the dura, which are pain sensitive. The brain itself, the brain matter is non-pain sensitive, but the dura is sensitive because of these vessels. Now these vessels get activated and then secrete a neuropeptides, pain mediators, which actually go on to affect the trigeminal ganglion. And from trigeminal ganglion, it goes to the spinal trigeminal nucleus. And from spinal trigeminal nucleus is the sense up to thalamus and goes to the cortex for the conscious perception of pain. So this is the general model of the craniocervical pain. So if you have a migraine, you start with this, inflammation of the dural vessels, and then it goes on to involve the trigeminal ganglion, the spinal nucleus of trigeminal at the trigeminal cervical complex, to thalamus and the cortex. But then if you look at it in detail, how does this meningeal nociceptors are getting activated? They are getting activated by a nucleus called the superior salivatory nucleus, which is the principal parasympathetic nucleus in the brainstem. Now, this nucleus actually is doing a forward loop of autonomic loop in which it is actually activating the sphenopalatine ganglion, which is the parasympathetic output to the cranial structures. And through that sphenopalatine ganglion, it is going into involve the blood vessel. And then once these blood vessels are involved, they're getting dilated. There is a neurogenic inflammation. And this particular afferent volleys, because the neuropeptides secreted, are going to affect the trigeminal ganglion and subsequently go into the pain pathway. So the question comes, how does this superior salivatory nucleus gets activated? It is getting activated because of the hypothalamus has got a close relationship, close influence with the superior salivatory nucleus because of its action through this about 50 various which is now shown in red dots, various other areas in the brainstem. Through that, it influences the superior salivatory nucleus, and it therefore can get triggered by olfactory stimulation, by food and sleep deprivation, stress or post-stress. So various structures can therefore through hypothalamus get activated within the brain, especially the brainstem, leading on to the activation of superior salivatory nucleus, leading on to the activation of sphenopalatine ganglion, leading on to the inflammation in the blood vessels in the dura, leading on to the neurogenic soup, and this soup is actually triggering the trigeminal ganglion and then to the spinal nucleus of trigeminal to cause the conscious perception of pain. So this has been shown by the David Doddick's diagram, that you have this actually the superior salivatory nucleus, which is actually activated by many structures like periaqueductal gray, like the stria terminalis, like the paraventricular nucleus, the piriform cortex. So they are getting activated, and through the sphenopalatine ganglion, you are getting, and this various neuropeptides are being released, which are affecting the trigeminal ganglion and to the trigeminal cervical complex. So this is the first step in the initiation of the migraine pain and the hallmark of the premonitory stage. Now, if you talk about the neurotransmitters, not just one, there are multiple neurotransmitters that are being actually identified. And this is Lars Edvinson's study, and in which characteristically now we are actually focusing on two of them. One is called the CGRP, the calcitonin gene-related peptide, and then another is called the PACAP, that is the pituitary adenine cyclase activated protein peptide. So therefore, these two are the primary focus, but then there are lots of other endothelial release factors and other pain mediators like nitrous oxide, acetylcholine. They are also being released across these blood vessels through the nerves. So next question comes, okay, now we know that how does this nociceptive impulses are created in the trigeminal ganglion. So, but question is that then how does it go up into the brainstem and from brainstem into the cortex for the conscious perception of the pain? Now, there is a balance in the brainstem. There are two types of neurons, one called the excitatory neuron, which secretes the excitatory neurotransmitters, and then the others which secrete the inhibitory neurotransmitters. And actually, this converging inputs from the hypothalamic and brainstem neurons provide a high and low set points for the allosteric load, the amount of physiological or emotional stress that can be managed by the brain in patients who experience migraine, and thus determine whether the nociceptive signals are transmitted to the cortex. So merely the generation of nociceptive signals are not enough. The brainstem actually is going to decide that whether that has to go up or not. And this has been elegantly proved by these studies. They could actually show that there are the vesicular gamma transporter neurons, which are the excitotoxic, and then there are vesicular GABA transporter, which are inhibitory neurons, and they have an interplay in the brainstem in choosing whether the particular pain signal is going to go up in the brain or not. So question comes that what is the function of the brainstem then? In 1995, there was a group of workers led by Weller who actually produced this fantastic images in which they showed that at the onset of the migraine pain, these areas of the dorsolateral pons are lighting up, and which was further confirmed by Anish Bahara's group in 2001. And then they started saying that the brainstem is the generator of the pain. But actually, the dorsolateral pons is not the generator. Actually, the pain mechanism has already been generated in the hypothalamus. It's only at the level of the pons, at the level of the brainstem, it is the gate through which this nociceptive signal are going to pass. So they have found that if cyclical brainstem activity is high, the threshold is raised for transmission, and therefore the nociceptive signals are inhibited. But if the cyclical brainstem activity is low, the threshold is lower and the transmission is occurred. So this is going into a kind of this cartoon that they have shown that they have the cyclical activity in the brainstem. So you have the inactive state, you have the prime state, and you have the activated state. So only during the activated state the nociceptive impulse are going to come. I'll not go into detail because it's a kind of a cells which act like a switch on and off. So they decide that whether a particular painful signal is going to go up or down in the brain. A bit about aura. Now, the Brazilian scientist Leo first described this phenomena, which is known as cortical spreading depression in a rabbit, and then it was subsequently proven in the brain of a dog by James et al. And it's a slow spreading depression which starts posteriorly and goes up at the rate of about 2 to 3 millimeter, and in humans up to a rate of about 5 millimeter per minute. So what they have done, there's a very, very important study in which they could actually show the progression of aura in human brain in migraine patients, and they could show that there is a oligemia. The brain functions, the blood flow in the brain is decreased. But before that decrease, there is a small time when there is an increase in blood flow, and that is called the hyperemia period, and that is possibly related to the flashes, the zigzag lines, where Dr. Banerjee was talking about the aura. So those positive symptoms are related to this phase, and the negative, then the scotoma comes, the fogging of vision comes, that comes because of the oligemia. So this is a slow wave that spreads, and as you can see, the EEG activity also decreases from alpha to beta, and then it becomes gamma. So there is a progressive swelling of the brain activity, and it has to do with ion channels, and there is a local elevation of extracellular potassium, and there is a disruption of cell membrane ionic gradients, influx of sodium and calcium, and release of glutamate, again an excitotoxic agent. So this is propagated by certain, the neurons are joined together by certain junctions, which are known as gap junction in the brain between the glial cells and the neurons, and it is through this that this cortical spreading depression spreads. And then there have been drugs which have been devised to actually block this gap junctions to see that whether they can prevent the aura. We'll come to that later. So this is the aura. There is a slow progression from back of the brain to the front, increased in potassium, and as you can see, the EEG activity is dwindling. So let us now come, after we know that this is okay, we know the pre-moiety phase, we know the aura, but let us now talk about the headache phase, the trigeminal vascular pathway per se. So as we have already showed that there is this dural blood vessel, there is a trigeminal ganglion, there is a spinal nucleus of trigeminal, and through that, the pain message is going up to the thalamus, and from thalamus to the conscious perception to the somatosensory cortex. But you realize that it is not only going there, it is going to other areas. You're going to the motor area, it is going to the reticular activating system, to the auditory area, to the visual area, and to the, so therefore there, and to the insula. So there are a lot of actual cognitive, emotional, visual, vertigo, somebody mentioned about vertigo. So all this can be explained because this impulse is actually interconnected in a web-like fashion, and it goes to various parts of the brain. But the chief important thing that there is a peripheral connection. From this inflammatory soup, the response comes and travels to the trigeminal ganglion and to the spinal nucleus, and then there is a central transmission. So there is a peripheral arm and there is a central arm. So, in the last 2 decades or 3 decades, there has been a lot of experimental models that has been created based on this paradigm, based on this pathway. And we have got, stimulation of sagittal sinus, arteries or veins, or the stimulation of various parts of the brainstem that can be done in an experimental basis in the lab, and you can record the potentials from these studies. So they have given very, very insightful, ideas. The first thing is that it has been shown that the cortical spreading decoration is actually activating the blood vessels in the dura, but they are not the only effects, because if you see that the lignocaine, if it is injected in the trigeminal ganglion, it is producing a decrease in the firing. But once the cortical spreading depression starts and you still block the trigeminal ganglion, you still see that the firing is going on. So once the cortical spreading depression is initiated, it goes on despite having a peripheral block. So it has got both central as well as peripheral effects. Then, two more things are very, very important to understand at this point, which are known as peripheral sensitization and central sensitization. Now, what is sensitization? Now, once activated by endogenous mediators, the peripheral trigeminal-vascular neurons become sensitized to dural stimuli, meaning thereby that their response, the threshold for the response decreases and the magnitude of the response increases. So with a little, kind of a stimulus, you are getting a larger response and more frequent response. So that is called sensitization. And this sensitization, the peripheral sensitization, is responsible for the throbbing pain, because the moment this sensitization happens, the vessel starts pulsating. They become dilated, not only dilated, they become pulsatile and cause the migraine pain. And this has been proved by this, trigeminal ganglion recording. They have put the electrode here in the rat. And so you see that this red color, they have done the MRI of the rat, and they could find that the trigeminal ganglion is activated. And once they are activated, they are actually showing that, this responses. This is before the peripheral sensitization, and this is after peripheral. You can see the amplitude and the frequency of the discharges is happening. And this is causing the pulsatile nature of the pain of migraine. Similar thing is also going to happen in the central structures, and that is called the central sensitization. And once it happens, it becomes very difficult to avoid the migraine attack. And in fact, this is responsible for the clinical symptom of cephalic allodynia and extracephalic allodynia. So what you see that, cephalic allodynia was the small area of pain along the eye is there at the start, but once the sensitization happens, there is a large increase in amplitude and the frequency, a larger area of involvement in the cephalon, in the brain, or in the scalp. So even if the spectacles hurt, the bangles, the earrings hurt, the scalp hurts. So all these are cephalic allodynia. And in patients, when you do that experiment with artificially triggering the nociceptors, you see that after some time the extracephalic, because of the thalamic involvement, they also happen. So many migraine patients during the attack will also say, there is a lot of pain in the hand. The question that was asked, there's a lot of pain in the limbs, which is also a manifestation of an extracephalic allodynia. So this is, then our picture becomes more complete. We have this inflammation that goes and involves the trigeminal ganglion. Also, there is input from the face and the surrounding cranial structures from B1, B2, B3. Also, the neck muscles become painful. They also send the signals, and they all converge at the trigeminocervical complex. And from there, it moves up to the thalamus and to the various parts of the brain to have the conscious perception of pain as well as other side effects. Now, one important component is a CGRP. As I said, it's a potent vasodilator, and because it is a neurotransmitter that can enhance the synaptic transmission mediated by glutamatergic signaling, elevations of CGRP can be detected in jugular venous blood during the migraine attacks. An intravenous injection of CGRP can trigger migraine in patients of migraine, but not in normal persons. So all this suggests that CGRP has got a very important role to play, and it acts on various levels in the trigeminal-vascular pathway. And therefore, it makes a strong candidate to be modulated, to be blocked, or to be modified by drugs, which Dr. Ravi Shankar is going to talk about. So this is again showing the various way the trigeminal-vascular pathway can be activated by CGRP and CGRP receptors. So this is again the Doddick's diagram. So what is the summary? Summary, if you want to ask me in a simple terms, as a layman language, that migraineurs, because of their genetic predisposition, have a hyper-excitable brain. Their brain is more responsive to external stimuli, and the brain is not able to process them in quick manner. So because of the various types of triggers, because of the inherent hyperexcitable nature of the brain, there is a altered homeostasis because of the hypothalamic involvement to start with, which actually alters the parasympathetic tone. That parasympathetic tone alteration leads to meningeal vessel activation. The vessels dilate. There is an inflammatory soup that is created, which is called as a sterile neurovascular inflammation. And also, there is an inherent defect sensory processing by thalamus and brainstem because of the cyclical nature of the neurons there. So both this actually meditate the fact that the painful stimuli, the nociceptive stimuli, actually pass through the trigeminal ganglion, the spinal nucleus of trigeminal, into the brainstem, and then they let go up to the thalamus, and from there to the cortex to cause the pain. There is a subset of patients in which possibly the CSD is important. That also causes meningeal inflammation and neurovascular inflammation. And also there is a central activation. And final common pathway is the activation of trigeminal vascular pathway. And once the peripheral sensitization starts happening, the patient starts getting the first features of the throbbing pain that starts. And with period of time, if you don't treat at that time, the patient will soon get a central sensitization with many other painful areas in the head, scalp, and other parts of the body. So for the acute treatment, you can actually block this by either by the G protein coupled receptors, which are called 5-HT, 1B, 1D, and 1F receptors, which can be pre-junctional, post-junctional, or in the neurons or in blood vessels, which essentially will cause the constriction of blood vessels. So these are basically the triptans and the ergots. Ergots also have some action on the dopamine-like receptors. And also you have the GPANs and the monoclonal antibodies, which Dr. Ravishankar is going to talk about. They are also acting by decreasing the release of the CGRP and also acting on the CGRP receptors to affect the same thing. So therefore, these are the targets that have been based on pathophysiology we can get. And for preventive therapy, you can actually have this model, and actually you have this input either from the trigeminal to the spinopalatal to the spinopalatal ganglion, to the eyes for the parasympathetic side effects, to the trigeminal you can have to all the three trigeminal nerves, and cervical area, the neck area, to the cervical complex. And so you can have a greater occipital nerve block, occipital nerve stimulation, Botox injections, multiple sites you are actually blocking the peripheral nerves, multifocal nerve blocks, and transcutaneous stimulators. In order to block that CSD, you have a drug called tonaberset, which is a gap junction inhibitor, as I was talking about, that actually is very helpful for prevent aura, but it does not affect the headache part. And there are a lot of preventives which have been shown also to affect the CSD in various studies. Then you have got, as I said, CGRP antagonists. They are the mainstay now. You can modify the cortex because the cortex again is going to influence the function of the hypothalamus by a transcranial magnetic stimulation. You can have the hypothalamic involvement being prevented by either a neuromodulation of the hypothalamus by doing a hypothalamic deep brain stimulation, PACAP by antagonist, by having the antagonist to the pituitary adenylate cyclase peptides. You can also have the neuromodulation involving the thalamus. You can also have a non-invasive vagal nerve stimulation, possibly affecting the brainstem and the parasympathetic loop. So this is in all the pathophysiology has to offer to you, showing you the various targets where you can actually get into if you know the pathophysiology. So what has changed in migraine pathophysiology and the treatment? The change is that now we have a specific mechanism-driven drugs like the CGRP antagonists or the receptor blockers, which can actually alter the migraine pathophysiology. So despite there are a lot of loose ends still, and migraine, I can still say that it's still a riddle, still wrapped in mystery and inside an enigma. Thank you very much for your kind attention. So I think So one question was that maybe Dr. Ravi Shankar can answer this. Should a psychological evaluation be a must before diagnosing migraine in children and adolescents?
Come again,
Should
David.
a psychological evaluation be a must before diagnosing migraine in children and adolescents?
It need not be a must. I would say that it can be helpful, but it's not so easy to do it below 12 or 14 years of age. So why it is helpful is because there is a lot of educational system stress, which leads to some amount of anxiety, depression. In fact, we have a number of patients who are going up for these multiple exams like NEET and other exams who run into problems of comorbidity. So therefore, if there is a chronic headache, which starts off like migraine, and you find there is refractoriness to the treatment, that is the point at which you would also get a psychological evaluation done in order to make sure that there is no, and sometimes it's difficult for the parents also to know which headache is genuine and which headache is not genuine in children who have multiple reasons, particularly with online education now for the last 6 months. We are seeing a lot of new types of behavior patterns in children. And so therefore parents are getting confused that in spite of medication, they are not improving. So definitely there is an indication for psychological evaluation above the age of 12 in children who have chronic headache.
Yes, I think, I mean, if you have that facility, then I think you should get that facility utilized, because that's an important thing. There are a lot of issues which parents don't know about their children. And in fact, when we deal with the migraine with children in our clinic, we find that there are lots and lots of issues with them about which the parents are totally oblivious. So therefore, a psychiatrist or a psychologist might help. Now, this is for Dr. Sanjay Prakash. This is a very interesting question that why do women suffer more with migraine than men?
Oh, definitely there may be some hormonal issue, because when we use just the prevalence say before the menstruation and after the menstruation, roughly prevalence male female is almost equal. So before menarche and after menopause, roughly male female ratio is equal. So possibility of hormonal behavior is there. Maybe many other causes, but most likely
Yes.
it is the hormonal.
So the one of the most important causes is of course hormone, and of course the relative concentration of estrogen versus progesterone in women. So that is one important thing. But then there are now some other avenues also been explored. One is that in experimental mice experiments, it has been shown that the female mice actually is having a greater severity of the cortical sparing depression, and the reaction to the cortical sparing depression is much more than the male mice. So that might also be an important factor. At least partly that can explain the female. Another thing is that there is one study from the Mayo, from I think Harvard, this Noshin Hatzakani's group. So they have shown that without being kind of gender bias, as a general thing, that the female brains are slightly different in architecture than the male brains. So there might be some inherent fine structural abnormalities in female migraineurs compared to the male migraineurs. So that might also be responsible for the differences. So this question, Dr. Banerjee. So what is the importance of yoga, for the migraine brain? I mean, does it help in preventing attacks? Would you find it useful?
Yeah, I mean, among the ancillary treatment, a lot of things have been talked about. We have talked about cognitive structural improvement, cognitive behavioral things and feedback. And yoga is also another way of, it probably helps in chronic migraine and to overcome this problem. So yoga has a role in migraine.
Right. So in fact, recently there has been a paper which has been published in neurology by AIMS, Dr. Rohit's group, and it has shown that yoga did help in that. Also the class 3 evidence, but it has shown that it does has role in prevention of migraine. So obviously, it's such a thing, as I said, that because it's such a wide neuronal activation, and if you have this way to calm down this hyperexcitable state, So then possibly it might help. Of course, this needs to be proven by more rigorous studies. Now, next question is to Dr. Thomas Matthew. Thomas, are you there? Um, so this is the question is that which migraine patient needs a CT scan or an MRI? Since most of the patients of headache will come to you and say that, oh, doctor, let me get a CT scan or MRI. So how will you choose?
So the most important question is it episodic and do you have pain-free intervals? If you have, it is episodic in nature, fits the criteria, you have clear-cut pain-free intervals, then may not need to do a scan at all. So your headache diary comes handy in that to know the exact frequency. But if it is a continuous headache, there's a change in pattern with respect to frequency, duration, intensity, then you may need a scan. And especially if it is associated with other symptoms like loss of consciousness, any focal deficits, unusual hemisensory symptoms, persistent auras. So anything you think of a complication, but most of the times scans are normal. So sometimes it is like a patient demands a scan. They tell that my headache is very severe, doctor. How do you explain this? So sometimes you may have to do just to pacify the patient to say that it is nothing is there. But for a educated person, if you can explain that the migraine, one of the important features is it is moderate to severe in intensity. So migraines are severe headaches. So that we know that it is severe. If the pattern, you have a particular pattern and you have pain-free intervals, that tells you that it is migraine, nothing to worry, give a headache diary, give the medicines. So sometimes we give the option to the patients because of the medical legal nature of things. You tell that you maintain the diary, and if you think our medicines are working, you can wait and watch. But if it is not working and your intensity is not coming down, your frequency is what, you may do it. Because sometimes you may land on a
I know. I mean, it's a very important question. And I'll ask Dr. Ravi Shankar because he has been practicing exclusive headache medicine for the last 40 years. So, with the increased litigation, so what are your, conditions in your practice where you'll definitely say that, no, I must get the MRI or CT scanner for this patient?
Yes.
That will be useful for our listeners. These are the patients we must do.
Yeah. Number one is whenever there are any of these red flags and you suspect the possibility of a secondary headache, regardless, you would definitely go with a scan. In the scan, I would say that go with an MRI because you are, as Devashish has rightly said, you are today in an era of high litigation. So definitely an MRI. And I usually go one step further. If I have a little bit of suspicion also, it's always an MRI with contrast. And if I have more suspicion, it's an MRI with contrast with an MRV. And if I strongly suspect a vascular malformation, an MRA is also included. So if you have any of the red flags, the most dangerous red flag is a new onset headache, where we have seen surprises, particularly in the pituitary area, the paracavernous region. So these are hidden areas in the brain and the posterior fossa. So therefore, if you have a new onset headache, and then of course the red flags, the SNOOP4 and all that, which I'm not going to talk about now because most of the audience would be aware of that. In addition to this, there are situations, for example, when it doesn't follow the guidelines laid out by the American Radiological Association also, where you would do a scan, is when you're seeing a child, it gives you much more time to treat the child. If you do a scan, reassure the parents, and then you play around treating migraine with your change of drugs, then you're definitely going to get more success in the treatment. And as Thomas said, there is a reassurance scan which is required for all educated patients, because if you don't do it, someone else is going to do it. And if there is a meningioma or an cyst found, then they are going to come back to you and tell you that you have missed something. The other situation where a scan helps is when online consultations are done and you cannot see the fundus, and you have a patient with chronic headache where it could be idiopathic intracranial hypertension. In that case, when you do an MRI, and you see changes of IIH, then you are at a good advantage to treat that with further investigation after admission. So these are many of these situations where today it is being done more easily than what it used to be done 15 years back, when we had to follow the guidelines and the rules and we were more clinical oriented. Today it is fear oriented. And definitely, I would do a scan much more easily than what I used to do earlier in my practice.
Correct. So because I am a member of the, Delhi Council for this redressal of the complaints, medical legal complaints, and I have been actually attending this. And in the last 1 year, I've had 3 such cases where actually the headache patients have complained later on that, well, our scans did show something later, and which was being treated as migraine. So one has to be, certain, and maybe that some of them are just incidental. They are not related to the migraine, but still they go and, doctors have to face harassment. So I think you have to keep your toes up, and in nowadays, because there might be a possibility of litigation. So therefore, you need to be careful about it. So before taking up further questions, I'll now request Dr. Amit to start with his case presentation. And Dr. Amit Shankar Singh is associate consultant of neurology and a very good neurologist working at Fortis Hospital at Mohali, Chandigarh. And he has been my younger colleague, and he has been from GP Pant. So Dr. Amit, please share your screen.
Good evening, sir. Good evening, everyone.
Come a little closer and speak a little louder.
Yes, sir. Good evening, everyone. Thank you for giving me an opportunity to speak. And special thanks for Dr. Debashish, who is my mentor, my guide, and who told me everything about headache medicine and neurology also. So continuing with the migraine, especially after talk of Dr. Tapas. So I am taking a case with history of migrainous headaches, visual aura, and palinopsia in a patient of sarcoidosis. So this case is about a 42-year-old male who was diagnosed as a case of sarcoidosis 6 years back and was on intermittent therapy. And he presented with episodic migrainous headaches with visual symptoms since last 2 months. And he admitted in our department with one episode of jerky tonic-clonic movement of right hand. So first coming to the headaches, which he was suffering from last 2 months, and these headaches were episodic, associated with photophobia, phonophobia, nausea, and restlessness. The headaches were hemicranial or holocranial, and from sometimes the headache were hemicranial at the start and then became holocranial. Throbbing or pulsating in character. Associated with these headaches were of duration 2 hours to up to 24 hours with gradual onset and peaking from 2 hours to up to 6 hours, and in the frequency of 2 to 4 times in a week. So quite frequent, these headaches were quite frequent. And for these headache, patient visited some local physician who thought to be these as migrainous headache and put the patient on oral analgesic naproxen and flunarizine. So along with these headache, patient also had visual symptoms, and these visual symptoms were preceding headache and sometimes without headaches also. So I want to tell you, I want to give the description of the visual symptoms, but I want to show the video where the patient is exactly telling how these visual symptoms are. And so here the patient is telling about his visual.
Mr. Amit, I think it is not audible.
Okay, sir. Is it audible now?
Oh, it's not visible.
Only visual things. I think you should explain.
Yeah. So the patient is telling about visual aura, which is a ring-like structure coming in the right visual field, and it has zigzag border and like vapors. Along with the patient is also telling about the palinopsia, which is persistence of the image of any bright object or any image, which is whenever he sees the patient anywhere else, this object persists, this bright object persists. So very persistent with the palinopsia.
What you can do, Amit,
Yes, sir.
you
Yes,
can
sir.
actually, there is on the left hand side of the slide share, there will be a tick box with a videos or the audios on.
Mm-hmm.
You have to stop share.
Okay.
Stop share and then do a share again.
Yes, sir.
First do the stop share and do a share again.
Yes, sir.
And you see on your lower half of the left side of the screen share, you'll see that option that do you want the video audio on?
Yes, sir.
Are you finding that? Once you start.
So I am not finding that option.
No, lower down. You are talking from a computer, this thing, no?
Yes, sir. Yes, sir. Yes, sir.
So once you open the share screen, did you open the share screen?
Yes, sir.
So yeah. No,
yes.
Before that, in fact, before you start sharing, you tick the there is a one checkbox which says that audio on. On the left hand side downwards. Did you find that?
Sir, I'm not able to find that.
Sir,
okay, then.
Yeah, audio is जब शेयर स्क्रीन आप करोगे ना तो नीचे एक ऑप्शन आएगा कंप्यूटर ऑडियो देन स्टार्ट, वो आप ऑन करना पड़ेगा.
Share computer sound?
Yes. Yes.
Okay.
Now you play.
Now you play.
Yes.
जी क्या दिक्कत हो रही है आपको बताइए.
Is it audible now?
राइट वाला जो पोर्शन इस पे ऐसा रिंग्स दिखाई देता है.
Yes sir. Yeah.
कैसे रंग का रिंग होता है?
रिंग जो है दैट इज जैसे वेपर टाइप नहीं होता, भाप टाइप होती है कोई चीज ऐसे करके.
अच्छा.
ऐसे चीज ऐसे रोटेट कर रही है ऐसे और वो कलर नहीं है और वो ब्लैकिश है ऐसे करके रोटेट कर रहा है.
सिर में दर्द तो नहीं होता?
हाँ, इस जगह पे.
ये रिंग के साथ सर दर्द होता है या अलग होता है?
रिंग के साथ साथ होता है. उस समय ब्रेन काम नहीं कर रहा होता इतना ज्यादा.
अच्छा. और दूसरी चीज क्या था वो आप बता रहे थे कि चीज
अगर मैं कोई ऑब्जेक्ट देख रहा हूँ, कोई कलर देख रहा हूँ या कुछ भी देख रहा हूँ, कोई छोटा सा सब, वो मुझे जब वो प्रॉब्लम आती, कभी प्रॉब्लम आ जाती तो मुझे मल्टीपल हर जगह पे दिखता रहता है. मतलब जहाँ भी मैं देखता हूँ वो सबसे पहले वो ऑब्जेक्ट जो है वो ज्यादा वो ग्लो करता रहता है हर जगह पे.
अब दूसरी तरफ देखेंगे उसकी जगह पे भी देखेंगे तब भी वही दिखता रहता है.
मतलब हर जगह पे ही दिखता रहता है. हर जगह पे दिख रहा होता है.
और वो कितनी देर तक रहता है ऐसे?
काफी टाइम तक रहता है. मतलब फिर
कितने मिनट्स या घंटों में?
मतलब मुझे आधा पौना घंटा लेटना पड़ता है आंखें बंद करके, तब जाता है वो, नहीं तो नहीं जाता.
सर में दर्द भी रहता है उस वक्त?
हाँ, सिर पे कंफ्यूजन रहती है, कंफ्यूज रहता है माइंड और मतलब काम नहीं कर रहा होता माइंड उस समय.
ठीक है. ये कितने दिनों से हो रहा है सर?
ये पहले स्टार्टिंग में जिस समय मुझे अटैक नहीं आया था तो उससे पहले ये होता था, पर जब ये ट्रीटमेंट हुआ तो फिर बंद हो गया. पर ये अभी 1-2 महीने से फिर शुरू हो गया.
So the patient in this video was telling about two important visual symptoms. One was translucent ring-like structure resembling vapors with zigzag borders suggestive of visual auras. Another visual phenomena, that is palinopsia, because he was telling persistent of white images, bright images or object even after the removal of the object. So these visual symptoms were gradual in onset and lasting maximum to an hour, and these were preceding the headache and sometimes without headaches also, and they may last up to an hour and along with headaches also. So these were the headache and visual complaints of the patient, but he presented in our emergency with episode of tonic-clonic movement of right upper limb, and that lasted for 1 to 2 minutes only. And on examination, patient was conscious, oriented with mild grip weakness of the right hand and without any other motor weakness. The rest of the examination was normal. Even fundus examination was also normal, this patient. So past history and treatment history, as I have told, since last 6 years, he was a case of sarcoidosis. And from last 5 months, he was started on oral steroids because of the worsening respiratory symptoms. So this was the treatment and past history of the patient. So with this history, headache, visual symptoms, and one episode of tonic-clonic movement, there were few possibilities in this headache. Obviously, patient was treated as migraine. Primary headache was kept a possibility by other physician, and migraine with aura could be a possibility with visual auras present in the patient, though palinopsia rare in migraine, but it can be seen in migraine also. And the next possibility was obviously second headache because red flags were present, new onset of the headache was there, and the patient had some focal deficits. The third possibility was occipital lobe seizures. Now here, as Dr. Tapas also told, that we have to differentiate epilepsy or seizures with headache, that too migrainous headaches with OSA. So in this patient, the aura, visual aura was classically of migrainous character, but this tonic-clonic movement of the patient was also present. So we have to put this this patient in a category of secondary headache because of the red flags, along with history of seizure episode, occipital lobe seizures also. But still the query was there, and for this the workup was done and urgent imaging in the emergency was done. MRI brain was advised, and surprisingly patient has large lesions, multiple ring-shaped lesions in left parieto-occipital lobe along with perilesional edema. The T2 images are showing, sagittal images are again showing, coronal images are again showing these left parieto-occipital ring-shaped multiple lesions, and the contrast image was showing ring enhancement and conglomeration in these lesions also. So with these imaging findings, now we can put this patient in a category of secondary headache mimicking migraine with visual aura, and the cause of this headache could be, it was intracranial space occupying lesion, that too in left parieto-occipital ring enhancing lesions. So the patient can be kept in the category of 9.1, ICHD 9.1, that is headache attributed to intracranial infections. So from the primary headache, migraine, migrainous 1, 2, 3, 4, it comes in the secondary headache and 9.1 of the ICHD. So this differential of these ring enhancing lesion could be pyogenic, tubercular, parasitic, fungal, neoplastic, inflammatory, or neurosarcoidosis. And for these initial imaging finding, patient was started on anti-epileptic treatment, and anti-edema treatment was also started. In view of conglomerated lesions, ATT was started empirically along with the IV antibiotics, possibility of pyogenic abscess. So further workup was started, blood investigations were sent. TLC was slightly increased with 12.8 value. ESR was quite high, 104. X-ray was normal. Mount-Took test was advised, which came further later on came negative. ACE levels were sent, which came later on very high. And CT chest was advised. CT chest was again showing findings of sarcoidosis with lymph nodes, bilateral hilar and paraesophageal, and multiple ground glaze haziness in lung field. So on the third day of the admission, patient was admitted in a ward. Patient was quite stable, but on the third day of admission, patient became drowsy and also developed right upper and lower limb weakness along with right visual field defect. So an urgent CT scan with contrast was performed in this case, and you can see the inflammation has increased, the edema has increased, and there was a midline shift also, because of which probably this patient became drowsy and weakness also developed. And patient was immediately shifted to ICU, and a repeat MRI with contrast was also performed. And in this MRI, we can see the lesion load is increased, the edema, perifocal edema has increased, and the midline shift we can see in T2 and FLAIR images. And the ring enhancing lesions are also increased. So within 3 days, patient has this increase in the ring enhancing lesions also. So our treatment with ATT and antibiotic was not working. So we were thoughtful why this is there. And also as the midline shift was present, we have to take an urgent decision. And in the images, we can see the ring enhancing lesion causing midline shift. So an immediate craniotomy with pus drainage from one of the large parietal abscess was done. And this was the pus of the patient. So this is a frank pus. So it was immediately sent for the microbiology and the aspirated pus for histopathology, also the tissue around the cyst. And on HE stain, we can see there are organisms, filamentous with multiple branching, which is not appearing to be tubercular, as tubercular bacilli are elongated without any branching. This is hyphae-like organism. Again, in modified ZN stain, it was positive for modified ZN stain. So we can say filamentous beaded branching hyphae-like organism. And this, according to our microbiologist, was a nocardia, not tuberculosis or not any other thing. So in these images, we can see the organism. This image is showing beaded character of the organism, and histopathology was showing acute inflammatory cells, hemosiderin-laden macrophages, and organism. Again, organism was present in the histopathology. So this gram-positive modified acid-fast beaded filamentous branching hyphae-like organism was nocardia, and it was grown in the Bicemedia also, and species isolation by PCR was done, and it came out to be Nocardia fascinica. And susceptibility testing was also done, and it was susceptible to imipenem, amikacin, minocycline, and Septron, that is trimethoprim xanthamethasone combination. So this patient was started on initial intravenous therapy with Septron and imipenem for 4 weeks. ATT was stopped, steroids were and stopped, and the patient showed improvement with this intravenous therapy. And after a month, patient was shifted to oral Septron only. So this is the recommended therapy for the nocardia patients. And immediately post evacuation, we can see there was the midline shift has gone because of the evacuation. And this is the imaging after 3 months. So patient was followed up, and after 3 months, we have gone for this imaging, and we can see the lesion load has increased. The inflammation has increased. There is no midline shift now. Even the contrast imaging is not showing any specific ring enhancing lesions now. So the patient was followed up. The limb weakness completely improved, but the headache and visual symptoms were persisting, and still they are present. So this video, which I have shown you, is the video after this all happened. So patient earlier had these symptoms, migrainous character, headache with visual symptoms, and for some time these headache symptoms subsided, but later on again patient had these symptoms, episodic symptoms with visual symptoms, visual auras, and palinopsia. And for this, patient still on anti-epileptics, and for headaches, patient is on topiramate and naproxen. The headaches and the visual symptoms are tolerable. He never had seizure after that. So this case shows, as Dr. Tapas also showed, that patient with headache, visual symptoms, and some focal deficit or seizures can mimic or chameleon like a migrainous headache, and patient need further workup and need to be differentiated with other disorders. And the learning point from this headache is any new onset headache, visual symptoms, and focal seizures, suspect secondary headaches. Immunocompromised patient with headache, also a red flag for the secondary headaches. Other uncommon CNS infections besides tuberculosis should be considered, especially in immunocompromised patient, and proper identification of CNS infection and timely intervention may save a patient's life. So this was the crux of the case. Thank you.
Thank you, Amit, for an excellent case. I mean, I think it is one of the very, very interesting case I've seen after a long time. Dr. Ravi Shankar, your comments, please.
Sir, unmute, sir. Ravi Shankar, sir, unmute.
Yes, go ahead, sir. We are not able to hear you, sir.
Amit sir, stop the screen share. Amit sir.
Hello.
Hello.
You. Okay, I think Dr. Ravi Shankar, you can actually then log out and then again rejoin. Probably something has happened on your microphone.
I have unmuted.
Yeah.
We are audible, sir.
Yes, sir.
Now you are audible.
Okay, now it's, yeah, now, Amit, that was an excellent, not only an excellent case, but also very well presented in the right sequence and all the right suspicions at the right
Thank
time.
you, sir.
Now, this would have been a difficult problem in any scenario, in any institutional management. So I don't think that you went wrong. And this is the situation where we find that we have to be alert to the identification of a secondary headache. And these end-stage dilemmas are always there, and surprises do turn up. This is like a CPC material that you have shown. So I think it's an excellent presentation.
Right.
Thank you, sir.
Dr. Matthew,
The last
you wanted
slide
to
was
say
very
something?
informative. When do you suspect and go in for imaging in a secondary headache? And also, I would like Devashish to comment on, quite often the secondary pathologies perpetuate the headache beyond, even when the pathology is cleared up on your MRIs, you find that the patient presents with headache which is intractable to whatever medicines we give. How would we explain that?
Yes. So that's a dilemma. So actually, technically speaking, although it would be considered prima facie as a secondary headache, because the patient had a relief of headache immediately after operation, but since again the headache has come up and patient has to be treated with an anti-migraine drug. So the question remains that whether he did have a primary pathology of migraine, which just got exacerbated because of the secondary pathology and got some relief after the removal of secondary pathology, and now the primary pathology again has come up, because he also tends to have a visual aura. I have got a collection of about 4 or 5 patients, especially with tuberculosis, neurocysticercosis. Even when they are treated well, they get better, but this kind of auras and headache episodes, they remain.
Yeah.
So that is, Westerners will not believe it, but this happens. I find that this should be labeled both as a primary and a secondary, from my point of view.
In post-surgery headache is also a possibility here. Post-craniotomy headache.
Yes. But then the patient is also having that typical aura which he was having earlier also, right? Okay.
Yes, sir.
So anybody else want to like to comment, Dr. Banerjee?
Yes, I remember a similar case presenting with palinopsia. I think palinopsia is a characteristic feature. One can have a space of mind lesion in the posterior parietal region where you can get palinopsia. But that patient didn't have headache, had seizure and palinopsia at times. It was neurocysticercosis in the posterior parietal region. So that's interesting. It's a very interesting case. And
right. So now we go to the next case. Dr. Matthews, can you share your screen and start with your case?
You're able to see, Nasa? I'm able.
Yeah. Make it full screen.
Yes, sir. Hope, sir, I'm audible, right? Sir,
yeah, you're audible, but your material has not come up.
Yeah, screen.
Shared already.
No, it's not coming up yet.
No, it's not coming up. The PPT has not come up.
Resume share. Resume share has come, sir. 1 minute. I'll do once again.
Your PPT is open, no?
Yeah, open, sir. Has it come now?
Yeah.
Yes.
Make it full screen.
Right.
Yes, it's full screen,
right,
sir.
Start.
Yeah, okay.
Start,
right.
please.
Okay. Thank you, Dabar sir, for inviting to be part of this program. It was a wonderful program, wonderful talks by Dr. Tapas, you and Dr. Amit, and it was a feast of headache and migraine and pathophysiology. It was wonderful to be part of this program, and I thank you once again for inviting me to share a small case. So I'll have a few points to tell after this case, and it's a very simple case. It's not a very complicated case. So I'll start the presentation. So this is the story of a 48-year-old man who came with headache and generalized tiredness. So I was in the outpatient, this is some 3 months back. He told, sir, I have continuous headache, which is going on for the last 10 days, but I'm very tired, unusually tired. So usually we see migraineurs, they also have tiredness, but he told, we can see that he's very much tired. We feel that he's really tired, he's a little pale. So headache was diffuse and severe in intensity, but there was no associated features. He had no vomiting, no photophobia, no phonophobia, no fever, no head trauma, no past history of headache. So this is a first time headache. So as the discussions were happening, how do you differentiate a primary and a secondary headache? So here we know that this headache is just happening and it is going on for 10 days. So we can't diagnose any of the primary headache disorders just like that because it's a continuous headache. On examination, there was no focal deficits, fundus was normal, there was no signs of any meningeal irritation. So professional diagnosis, I had no idea what headache he had because diffuse headache and tiredness, that's all the story. So not able to fit anywhere and it's a little short duration. So I didn't know what it is. And whenever we see headache, which we don't know and which doesn't fit into a primary criteria, we of course will do a scan. So we did a scan straight, we admitted and did an MRI. And the MRI showed, I'll just show the relevant pictures. The MRI was unremarkable except for a bulky pituitary. You can see that the pituitary is enlarged, but otherwise the scan otherwise is unremarkable. And when you see the images, you can see a bulky pituitary. And far away from the optic chiasm, there is nothing pressing on the optic chiasm. The rest of the brain is okay. You can see mild thickening of the sphenoid sinus here, but otherwise nothing much. And this is again another view of the pituitary. But if you see closely, you can just see a little thickening of the pituitary stalk there. And then this is a close-up view and finer cuts. You can see the pituitary stalk is a bit thickened and the pituitary is really bulky. So a contrast scan was done and it again shows bulky pituitary, which is enhancing. And then you can see the stalk, which is also a bit thickened. So this is the stalk, which is thickened in the coronal cut. We can see that. So other investigations were unremarkable because of the extreme tiredness and the pituitary swelling. We did a hormonal profile. Prolactin was normal, so there was not a prolactinoma. The serum cortisol was low, so there was evidence of hypocortisolism. And we started, gave him hydrocortisone supplementation. And once we supplemented the steroids, his headache completely disappeared. And then we had started actually on dexamethasone initially, and then the endocrinologist came and they wanted to give hormonal supplementation. So anyway, we had started dexamethasone. I thought we'll give Visolon for some time. So I just started Visolon at a dose of 60 milligram, and then I was slowly tapering. So this gives you a scenario where you have a headache of 10 days in a 48-year-old man with a bulky pituitary and a hypocortisolism and a pretty large pituitary looking like a macroadenoma. So now the question is, are you going to, patient is much better with the steroid treatment? Are you going to refer to surgery? And are you going to remove this macroadenoma and going to see, or do you want to do something? So the interesting point in this case is the thickened pituitary gland. In an adenoma, you won't get a thickened pituitary stalk. So that is a clue that it may not be a pituitary adenoma. So when you see like this, there are a few possibilities. So there's an entity called a primary or an idiopathic pituitary hypophysitis. It's a diagnosis of exclusion. So other diseases which can mimic bulky pituitary with a thickened pituitary stalk is tuberculosis. You can have sarcoidosis. You can have Wegener's granulomatosis, Langerhans cell histiocytosis, syphilis, Rathke's cleft cyst rupture, and even an IgG4 disease. You know, an IgG4 disease also can have a picture like this. So we investigated further, and there was CT scan of the chest was normal. There was no evidence of tuberculosis or sarcoidosis. Serum ACA levels were normal. C-ANCA was negative. Syphilis VDR was negative. And Langerhans cell and Rathke's, the radiologist not in favor of any Rathke's cleft cyst rupture, and IgG4 was negative. So we came to a conclusion of a primary bar an idiopathic hypophysitis. So then we continued the steroids, and the plan was to just closely follow up with a repeat scan. And then I did a scan on 29 June, that is almost 2 months after. And you can see the pituitary now. The whole bulky pituitary has become a very small pituitary, okay? And then you can see again, the coronal cut, a bulky pituitary has now become a very small pituitary. And then you can see all the size has gone, and his headache was completely better. And the pituitary size like that, it is improved, very significant improvement on follow-up. And still the stalk is a bit thickened, but you can see the pituitary bulk has improved very well. So primary idiopathic hypophysitis is a diagnosis of, after the exclusion of secondary causes, as we have just seen. And usually this diagnosis, because when somebody sees a bulky pituitary, the reflex is to send to the neurosurgeon. So they usually biopsy it, and in biopsy you get a diagnosis of primary and idiopathic hypophysitis, and you can have histologically 5 features, 5 types can be there. One is called a lymphocytic hypophysitis. Other is a granulomatous hypophysitis. Then you have a xanthomatous hypophysitis, xanthogranulomatous hypophysitis, and a necrotizing hypophysitis. And in this, the granulomatous one is the one which mimics a pituitary macroadenoma. And because it is closely mimics radiologically and clinically a pituitary macroadenoma, some clues may suggest it may be hypophysitis. And these clues are thickened stalk, a short duration of headache. All these things may point to idiopathic granulomatous hypophysitis. So there are reports, if you put this entity, and you can see a lot of other reports. And because, as you know, the pituitary and the lesions in the pituitary and around can have trigeminal autonomic cephalalgias also. So this is a report from Neurology and Neuroimmunology and Neuroinflammation Journal, where a patient with a granulomatous hypophysitis presents with a trigeminal autonomic cephalalgia and Horner syndrome, and they see this bulky pituitary. You can see the bulky pituitary with that stalk, the small stalk which is thickened. So when you see a bulky pituitary, just look for a thickened stalk. And if there is no visual field defect or anything, you may give a course of steroids and then wait for improvement. So these are other pictures from the net which shows a similar appearing bulky pituitary with a thickened stalk. So this is an entity of idiopathic granulomatous hypophysitis. And the most cases described so far are being diagnosed after surgery. And the diagnosis is reached only after histopathological studies. So it is worth considering the possibility of idiopathic granulomatous hypophysitis. And if there is no optic chiasmal compression and if there is no urgency, we may give a course of steroids, and then they will beautifully respond, and you can do a repeat scan after 6 to 8 weeks. So it has been postulated that if one suspects hypophysitis before surgery, improvement following steroid therapy may help in differentiating the two. So that's, in a way, we may avoid a major surgery, and then we can treat successfully these patients. A thickened stalk on MRI has been cited as the most characteristic radiological finding in favor of idiopathic granulomatous hypophysitis. And so the take-home points from my presentation is, when you have a recent onset headache with unusual tiredness, please think of a pituitary lesion and a hypocortisolism associated. And a bulky pituitary with a thickened stalk, always think of a granulomatous hypophysitis, which is well responsive to steroid treatment. And there is further more to the story, because when he came to me with the pituitary so much better, I sent to the endocrinologist. So what he did, he just gave a supplementary dose for hypocortisolism. I think they put on high zone, some 10 mg morning and 5 mg in the afternoon. But patient came with a recurrent paroxysmal hemicrania. And then when he came with a recurrent paroxysmal hemicrania, I just gave indomethacin and repeated the scan. His pain came down with indomethacin, but pituitary again became bulky. Then I realized that in this, you may have to give a higher dose of steroids, not just the supplementary dose of steroids. Then I put him back on Visalon 60 milligram again, and over a few weeks again reduced it. And now he's reached at 20, his pain has disappeared. So I think you need a little more higher dose of supplementation till the pituitary comes down, and we may have to maintain a little higher dose of steroids. And then if still it is not working, because we may have to give, I don't know, maybe rituximab or something like that. We will have to see if steroids are causing any problem. But this is an interesting case, and it is, I think it is one of my first case of pituitary hypophysitis and responding to steroids with a beautiful follow-up MRI. I think usually these patients go to surgeons and the endocrinologist, and endocrinologists are well, they know about this condition well than I think the neurologist. So that's why I thought it will be worth presenting, and Dr. Debashish also considered it a worth case, and I thank you for choosing this case and allowing me to present this, and thank you, Dr. Shankar, Dr. Tapas, for
Thomas, it's a beautiful case, and actually it shows that, you know, we always in clinical medicine, there is a great sense of uncertainty, and we get more surprised than, you know, often we get more surprised than otherwise. And, you know, the main thing is this, that you could actually treat the patient got well, and you could make a reasonable diagnosis without the biopsy. And of course, I have seen about 3 or 4 cases of pituitary hypophysitis, and the steroids are very helpful in this condition. And of course, you had a host of differentials, other differentials which you have listed. So I think the most of the questions that are said in the box, you know, suggested in the chat box, are pertaining to the treatment part. So I think we can go straight away to Dr. Ravi Shankar to start with his lecture of management of migraine, because most of the people are waiting for that. And then we can take the overall, you know, questions for rest of the talks, right? So may I request Dr. Ravi Shankar to share? Thomas, did you stop sharing?
Yes, sir. Yes,
yeah.
sir.
Yeah, thank you.
Thank you.
Dr. Ravi Shankar, please, can you share your presentation?
Am I audible and is the screen visible?
Yes.
Okay.
You can come a little closer to your you know, laptop so that, you know.
Yeah. Thank you, Debashish, for this opportunity and inviting me to talk on migraine preventive treatment. Now, the talk by Dr. Tapas and Debashish, both excellent talks, have set the backdrop for my talk on preventive treatment. And in spite of all the advances which Debashish spoke about, you often find that migraine is neglected in many areas, and most patients are not treated optimally. And there is a huge gap which exists between the theory and practice of migraine. So what I'm going to do in the 25 minutes that have been assigned to me is to talk to you on and try and evolve for you a plan to the approach to preventive treatment of migraine. I will talk about some of the traps which I see in practice, and with some take-home messages and some tips, I will try and tell you how to improve the outcome when you choose preventive treatment for migraine patients. I'm fully aware that headache is one part of your practice, and so I will keep it practical, simple, and try and stick to my time limit. Now, let me begin by re-emphasizing what Tapas told you. And this is from the World Brain Day last year, where migraine was chosen as the subject. And the speakers were all top class: Professor Bill Carroll, Lars Edvinson, the man who gave us CGRP, and Professor David Dodick. And they came together, the World Federation of Neurology and the IHS, they came together in order to send a message across globally that migraine is a very common and legitimate neurological disorder. So everything about migraine is now proven biology. So gone are the days when people would think about migraine as a psychological disorder. And it is the second most disabling disorder in terms of years lived with disability. It affects across all ages, races, socioeconomic class, and there is a high prevalence, more in females than in males, and during the peak productive years of one's lifetime. And because of the huge economic burden, almost $27 billion in a measurable country like the US, both episodic migraine and chronic migraine. In spite of all this, you find that migraine is still underestimated, underdiagnosed, and also undertreated. Now, in order to look at preventive treatment in an optimal manner, it's important that we know the entire migraine spectrum as it prevails today in the ICSD-3 classification of 2018. As Tapas had mentioned, a lot of new terms have come in and a lot of entities have been included. You find that chronic migraine gets a separate rubric of 1.3. You find that aura has been, migraine with aura has been subclassified. Basilar migraine is now to be called as migraine with brainstem aura. And you have complications of migraine. You also have a category introduced called probable migraine, where when you don't have all the criteria being fulfilled, you can put your patient in that box. And children have episodic syndromes. Now, why is it important for a talk on preventive treatment to be aware of the different subtypes of migraine? That is because we are going to talk about choosing the prophylactic drug according to the subtype of migraine. For example, if you have a patient who has hemiplegic migraine, you would go with calcium channel blockers as the first priority. And if you have a patient who has an aura which is difficult to treat, you would add levetiracetam and try out if that patient responds better. And for a patient with aura, you would go more with the anti-epileptic drugs rather than just the beta blockers. So these are ways in which subtyping the type of migraine you are dealing with is going to help you in treating the patient. Now, for preventive treatment of migraine, what is the most important thing? You have to conceptualize migraine correctly. We've had this throughout the session being re-emphasized. And most often we find that a lot of doctors tend to look at migraine and treat only the acute attacks. That is not just the only part to be treated in migraine. You definitely need to treat acute attacks correctly. But more importantly, you need to look at migraine as a chronic disorder with episodic attacks and look at reducing the frequency and severity of migraine in the long run. And why is it to be looked as a chronic disorder is because it's a genetically inherited disorder. So the genes are going to stay the same. The patient is going to stay in the same environment and have more or less the same lifestyle. Your drugs today are far from ideal. You don't have the perfect preventive drug as of now. And the design of migraine, the natural history of migraine is such that only a small percentage of patients remit. A lot of them persist, some of them progress. So it's a situation of what I call as a semi-locked in state, where once a migrainer is always a migrainer. And based on comorbidities, based on risk factors, you have episodic migraine progressing to chronic migraine, and you have the disability levels assessed through MIDAS and HIT6, showing that migraine is a highly disabling, debilitating disorder. So if you remember this, then most of the patients who come to you in tertiary practice and as specialists, you would find most of your patients require preventive treatment. Those probably who get away with attacks once in 2 months, once in 3 months, and need only treatment for their acute attack, probably see the general practitioner. But as consultants, what you see most often requires preventive treatment. Now, what is the plan which you must keep in mind when you draw a preventive treatment plan? First of all, you have to understand that no two migraineurs are similar. Everybody, you have to customize the treatment. You have to build a rapport. You have to educate the patient on what is going to be your treatment plan. And there are 3 pillars. One is lifestyle measures and control of triggers. The second pillar is every preventive treatment plan has to have a satisfying acute treatment in the background. So therefore, you have to draw all these 3 together. And then you draw the preventive treatment. And there again, you have the option based on what the patient prefers, based on what is the disability level of the patient, whether it should be only pharmacological, whether it should be pharmacological plus non-drug alternative treatment options, or if some patients prefer, it could only be alternative treatment options, which is now being accepted across the globe, and people are opting for it. And finally, the last slide, which Devashish had talked about, the future treatment options, which we still don't have today in our country, but in the next 6 months to 1 year, you are going to see a lot of that coming in. So therefore, we need to have an idea of what are the future preventive treatment options. So I'll briefly touch upon that area, but I'll more importantly focus on what is currently available. And the take-home message from this slide is that you have to remember that because of pharmacogenomics, it is not the same drug for every patient with migraine. Unlike in asthma or unlike in diabetes, where the patient would respond with similar treatment, every migraine patient has a unique genetic and a biological predisposition and a different threshold level. So therefore, this is an important point to remember when you choose to start preventive treatment. And what do I see in practice happening, which needs to be rectified? And this includes me also as guilty of not taking care of some of these steps, because if you are rushed in practice, you may not go through all the steps, but it is by doing it again and again that you take care of all these steps. What is the first thing to do? First is you have to focus and spend time on what are you going to plan for prevention. You have to do it comprehensively. You have to customize it according to the patient requirement, patient profile, the headache profile, many other factors. And you have to tell the patient what are the goals of starting a daily drug for a migraine patient. And you have to tell him that you're going to reduce the frequency, reduce the severity, reduce the disability. And you have to set the right expectations and talk of 50%, 60%, but do not talk of removing headaches. You are only reducing headaches. And a lot of patients tend to think that it's a 3-month course. It is not a course of treatment in a genetically inherited vulnerability. So please tell him that over a period of time, you're going to reduce the medicines on a daily basis, which is what they are worried about. But you have to reassure him that he will have to take it for as long as he may need it, because you do not have biomarkers. You do not have yardsticks to tell you the severity of the migraine, the threshold of migraine, unless you treat, or unless through the disability you gauge, you do not know whether he'll need 1 drug, 2 drugs, or more than 2 drugs. Then you have to educate him on the lifestyle, the importance of trigger control. You have to choose a specific migraine treatment option, and you have to stratify. So at the initial visit, you could go away with just 1 drug, but later on, if the patient refuses to, if the patient does not respond and his disability continues, he may need more than 1 drug. So gone are the days when there would be debates on whether it should be monotherapy or polytherapy. So the message I want to send across is there are many patients in practice, when they see a consultant, they would require polytherapy. So it is not wrong to go with polytherapy using drugs which have different mechanisms of action. The other fault I see in practice is a lot of clinicians tend to use the same favorite drug always. I know it is difficult to get things right the first time. We also never get it. But you have to understand there is a process of trial and error. So it is not to go with the same beta blocker or the same flunarizine for every patient of migraine that you come across. So you have to do a bit of trial and error and see what is the best drug that suits that patient. That is through follow-up. That is through titrating the doses. That is to understand the adverse effects and then change the drug, and giving it an adequate trial of 2 to 3 months, making sure there is compliance, making sure there is adherence, because there is no guarantee that the prescription which you have started is being continued. So you have to make sure of that. Look for comorbidities. Look for risk factors which might progress the patient from episodic to chronic migraine. High frequency, medication overuse, excess caffeine, stress, sleep apnea. These are some risk factors. And are there any coexisting illnesses which give you the opportunity to use 1 drug which tackles the migraine as well as the coexisting illness? Or is that coexisting illness going to limit your choice of drugs? And do you need to combine therapy? If so, combined therapy, combination therapies using different mechanisms of action will be more useful. So look at the patient profile. An obese patient would do well with topiramate, and a patient with a PCOD problem, a lady would not have divalproex as a choice. Look at the headache profile. What are you going to use for menstrual migraine? What is the perimenstrual prophylaxis? What are you going to use in vestibular migraine? Calcium channel blockers would be a good choice. And understand that there are special situations. Children need different prophylactics from adults. In pregnancy, there are very few prophylactics which are allowable. The elderly patients may have other comorbid illnesses which might prevent the use of drugs like amitriptyline. So therefore, take care of those situations. And when your treatment fails, try to analyze why is the patient not getting better. So if you try and analyze, you might get some reasons. And you should know that if the patient is overusing triptans or ergotamine or drugs containing caffeine and codeine, your prophylactics will not work. So upping the dose because your prophylactic is not working is just not the way to go. And finally, if you have problems and the patient is not improving, look at referring to a colleague. And in fact, just recently, I had the opportunity to refer a patient to Devashish because I was finding that the patient was refractory to all my efforts. So therefore, be ready to refer if you are stuck. And there could be somebody else who has some other ideas, and he might be able to help you. And look at future options. A lot of affording patients can outsource the drugs from the US, so that could be an option. And finally, a 10% group, do what you may, just don't respond. So the take-home message here is to understand that preventive treatment is a dynamic process and keeps changing. The goalpost keeps changing all the time. And it's based on empathy. So you have to be kind to the patient, and then you will see patients responding better. And these days, you also have Google, which prevents most patients from going with the drug that you have prescribed because every side effect is mentioned in Google, and they refer to Google much more than to you. Now, what are the indications for preventives? If you have a high attack frequency, more than one per week, if you have that situation where acute medicines don't work, and if for a severe type of migraine like hemiplegic or basilar brainstem or a migraine, the patient prefers that even if I have one attack a month, I would like to go with the preventive, then you need to start the preventive. And what are you trying to achieve through the preventive? You want to reduce the frequency, the severity, reduce the disability, and interestingly, it improves the responsiveness to acute treatment. So when a patient is not on preventives and he says these triptans don't work for me, you start preventives, you will find some of these situations are eased out by the triptan working. And definitely preventives will take care of progression of migraine. But what happens in practice is quite different. And in this study, they found that 40% of patients out of a total of 19,000 were candidates who needed prevention, but only 13% were taking it. And what happened at the end of 1 year? There was just 17% who were continuing it. 83% of people with migraine discontinue preventive treatment at the end of 1 year because of poor efficacy, reduced tolerability, and fears. Big number. So when you choose preventives, you got to explain to the patient, you got to tell them the goals, you got to look at the profiles, you got to be aware of the contraindications, the side effects, and you got to combine them, strategize prevention using current options. And there is a huge scope for alternative treatments in the preventive treatment of migraine, which is currently being largely neglected. When you stratify based on frequency and disability, what are you asking the patient for? How many days in a month do you get headaches? Better still, in order to diagnose whether it's episodic or chronic migraine, you could ask the question, how many clear days in a month do you have? Quite often you'll be surprised. The first answer is, I have 10 days of headache in a month. When you ask how many clear days, the patient says, I just have 5 days of clear days in a month. So it changes the picture completely. And as Thomas mentioned, these are questionnaires which you would use in order to assess the disability, the MIDAS questionnaire and the HIT6 and the calendar. Now, this type of a calendar tells you very clearly that you can differentiate between episodic and chronic migraine, where you have more than 15 days over a period of 3 months, and more than 80 of those days are migraine headaches. So they also respond to treatment as for migraine. So therefore, when you deal with chronic migraine, you've got to choose your preventives differently. The comorbidities have always to be asked for. Psychiatric disorders quite often comorbid in children, adults, and you have some neurologic disorders like epilepsy and stroke, which are more seen in migraineurs, and fibromyalgia, as was mentioned. Then you ask for the risk factors, which I have talked about, and look at the patient profile, look at the headache profile. Now, the guidelines, there are set guidelines, but sometimes you have to deviate from the guidelines. You have the American Headache Society guidelines, the Canadian Headache Society guidelines, the European guidelines, but you develop your own favorite choice of drugs based on efficacy, the level A, the first choice drugs which you will go with. Now, this is from the American guidelines, and the beta blockers, the add-ons are divalprox, the AEDs, divalprox and topiramate, amitriptyline, venlafaxine, and more recently, candesartan, and in children, cyproheptadine. And from the European side, because flunarizine is not available in the US, flunarizine is a useful first drug option, provided you're aware of the side effects and the contraindications. So look at the contraindications, the side effects, go with the principles, and you will find success in preventive treatment. The contraindications you have to watch out for: asthma for beta blockers, COPD for, again, beta blockers, and peripheral vascular disease, bradycardia, all of them. PCOD for divalprox. Always remember to ask if there is any plan for the patient to conceive. You can't start divalprox and the patient goes without knowing it and conceives. Then you can have problems with keratogenicity. And for topiramate, you would look at glaucoma, renal stones history, and if a patient has a job which needs alertness, for example, a pilot, you can't give topiramate to a pilot and he is taking care of so many passengers in the plane. Be aware of the side effects. I will not go through these in detail, but you have to be aware that certain things like fatigue, certain things like erectile dysfunction, so a male patient should not be started on a high dose of beta blockers, sleep, depression, these are things that can worsen, hair loss and weight gain with divalprox, and cognition problems with topiramate, sedation with flunarizine. These are some things which you should be alert to. Start low, go slow, start at an appropriate dosage, evaluate periodically, look for opportunities to use one drug with two actions or two drugs which combine well with each other. And when you see the opportunities, for example, if a migraine patient has hypertension, you can use a beta blocker or a calcium channel blocker. If a migraine patient has depression, you can go with a tricyclic antidepressant. If a migraine patient has epilepsy, you would go with an AED. And if there is bipolar disorder, you would go with divalprox. So these are the ways you would use, and sometimes you have to limit your choices. Now, what are the problems with what is available to us today? None of these are specific for migraine. They are all borrowed from other areas like antihypertensives, anti-epileptic drugs, antidepressants. And there are safety and tolerability issues. They take a very long time to start acting. And they always need titration follow-ups, which patients may not come to you again, and all the drugs do not work in all. So there is a definite drawback in the prophylactics which are currently available. So how can you improve the yield when you have these drawbacks? One is you go for alternative treatments, and this is an underexploited area. Patients are now becoming more receptive to alternative treatments. So therefore, you have to keep these alternative treatment options in your radar when you choose prevention. What we do now is conventional treatment. What we will add in terms of alternative treatments is going to be complementary treatment. And when you replace it, the conventional treatment with something else, that's called alternative treatment. And that is how the word CAM has come about, which means both complementary and alternative treatment options. So what are the modalities which fall under this for headache under the heading of CAM, what all can you do? One is nutraceuticals. This is why is it that most physicians do not go in for these things? One is because they are unaware of these options working. Two is you don't have extensive clinical trials like with the drugs. And three, the experience is limited. So amongst the nutraceuticals, you have magnesium, you have riboflavin, you have coenzyme Q10. These are all very well proven and established to help in migraine. Some of the others which don't have such extensive proven experience are butterbur or petacites and feverfew. And now you are hearing a lot about recreational drugs, but they are more for cluster headache, which are refractory. What else comes under the heading of CAM? Biofeedback, relaxation training, physical therapies, and an entirely new system, the homeopathic system, Ayurveda, yoga. So there is no harm in allowing patients to combine this, whatever you're doing, because it is going to add benefit. It is not going to take away from your treatment. In fact, these may not have the side effects which your current pharmacotherapy may have. And when should you, or when do patients prefer it? One is by choice. Two is when they feel they can't tolerate the drugs. When there are certain contraindications to the drugs that you're giving. And when you find that in pregnancy, you can use occipital nerve blocks for bad migraine. In pregnancy, you can use some of the physical measures, non-pharmacological. And you will find that there are studies which look at what are the reasons for CAM usage. And they also include recommendation by family and friends. And they feel that these drugs and these non-pharmacological are safer and do not have the side effects. So amongst the nutraceuticals, what are we looking at? We are looking at magnesium, which is now coming in a big way, riboflavin, coenzyme Q10. And we also now have a combination which takes care of magnesium, riboflavin, and coenzyme Q10 together. And magnesium works in many ways. And there are studies studied. This is a well-studied drug option. And one of the foremost researchers in this area is Alexander Moscow. And magnesium is associated with cortical spreading depression, low levels of magnesium. And also it induces platelet aggregation and influences serotonin receptors. And it controls vascular tone via the NMDA receptors. And you find that this pilot study, it works both acutely and as a preventive. This pilot study by Moscow in 40 patients showed that 50% of patients had low magnesium levels, and with 1 gram intravenously, once their magnesium levels came to normal, their status micronosis improved. And it helps significantly in menstrual-related migraine. So it has no side effects that you need to worry about in the normal dosage. It helps in children with migraine. And the only side effect when you exceed the required dose is diarrhea. It's contraindicated in kidney disease. And these studies have been reported in cephalalgia. And you find that there is a significant reduction in chronic migraine also when magnesium was used along with the other drugs. Riboflavin in a dose of 400 milligrams over a long period produces a significant reduction, and it works through being a cofactor in the Krebs cycle, and it has a vital role in membrane stability. And the only side effect that you need to worry about is diarrhea. Coenzyme Q10 used in many disorders throughout, and it works through activity in mitochondrial function. There have been studies with this drug too by Todd Rosen and Peter Sanders. They've studied this in about 40 patients, and they found a 50% responder. And Andrew Hershey has studied a big number of 1550 patients in the pediatric age group, and it's a useful drug in pediatric migraine. So therefore, you will find that it's an add-on which is useful. You will find it's useful in menstrual migraine, it's useful in pediatric migraine, and these are situations where you would definitely add these nutraceuticals. The non-pharmacological options, we've just had a brief chat about that during the question session. And you have cognitive behavioral therapy in a big way. And what about the future? Now, in the future, what is the sort of prophylactic that you're wanting? You want something with proven efficacy that improves the quality of life, that has few adverse effects, that patients adhere to, that doesn't need to be given on a daily basis, that is easy to administer, and that works where others fail. So what is the drug, or what is the option that will fit in these requirements for a future drug option? These are what Devashish talked about, the anti-CGRP monoclonal antibodies. Now, CGRP levels are raised in migraine. CGRP produces vasodilatation. CGRP present is everywhere in the CNS, wherever there is migraine pathophysiological derangement. And you have the G-PANTs, which were first introduced. This is a drug which was introduced by Olison, intravenously Olsegipant. Then you had Telsegipant. These were for acute migraine. And when they tried it out for chronic migraine or as a prophylactic, they found that it had liver enzyme toxicity. And so therefore, for some years, there was no research in this area. And now you have what are called the small molecules, which I won't be talking about because they are all used for acute treatment of migraine in place of triptans. Two of them are being studied also as a preventive, but by and large, please remember that the small molecules or G-PANTs are used for the acute treatment of migraine. For the prevention, what are we looking at? Now, the monoclonal antibodies, they are the drugs of choice for preventing migraine, and they prevent the, they reduce the levels of their anti-CGRP, and 4 of them are developed for preventive treatment. They are administered subcutaneously, 3 of them, and intravenously 1, and they are all having the suffix UMAB and ZUMAB, and they have minimal side effects. They act quickly, they don't need a build-up, and there is a sustained efficacy for over 1 month. The half-life is about 27, 28 days. So you can give it once a month and still have the efficacy. And there are 4 of them now. Erenumab is the one which is likely to come in first into the country, and it works against the CGRP receptor. The other 3, galcanezumab, fremanezumab, and eftinezumab, work against the ligand, the CGRP ligand, and the dosage is once monthly, and eftinezumab can be given once in 3 months. So this is the range of anti-CGRP monoclonal antibodies we're going to see in the future. They are going to have a big advantage over the currently available pharmacotherapy because A, they work in all patients, 2, minimum side effects. Compliance is not a factor, but it is not complete magic. There are reasons which we could enter into discussion later on that it's not going to take over the scene completely like magic, because you have some super responders, about 10 to 20% of them, but they still are in the range of 50% to 60% improvement and just a little in that range. So there are many other reasons why we choose them over the currently available drugs. And lastly, what do you do in refractory migraine when these preventive options, which I talked about, does not work? You can go in for the neuromodulatory options, transcranial magnetic stimulation, supraorbital nerve stimulation, that is Cephali, vagal nerve stimulation, gamma core, and sometimes you can buy time by doing an occipital nerve block. And lastly, that is the end stage, is to go in for surgical measures using the occipital nerve stimulation and sphenopalatine ganglion stimulation. So if I was to conclude by telling you how I would go in for preventive treatment of migraine, I would start with the pharmacological options. I would add nutraceuticals, and if it is chronic migraine, we would give a trial of 3 doses of Botox. If it doesn't work still, then you go in for, along with this, you would go in for non-pharmacological measures too. If it doesn't work, then we would look at the monoclonal antibodies, the anti-CGRP drugs, and G-PANTs only for acute treatment. And if G-PANTs come in for prophylactic treatment, preventive treatment, then atogepant and rimegepant are being tried for preventive treatment. Then finally, neuromodulation, and lastly, including the invasive surgical options. So this is what I would say, combine this with empathetic attitude to the patient's misery and suffering, and you have good outcome and improving the optimal. This is what I would call optimal management, preventive management of migraine. Thank you.
Thank you, sir. Thank you, Dr. Ravi Shankar, for a very, very comprehensive, lucid, and very informative lecture covering the vast range of options that is now available for the preventive therapy of migraine. And of course, some of these, as you said, that is not still available in India, but many of them will be available in the coming months, and we shall be, using them. So we'll start with the questions because there are a lot of questions on management. So first, I'll start with you, the basic thing that what is the maximum dose of propranolol that can be used? What are the precautions to be taken if you are using high dose of propranolol, and can it be combined with flunarizine?
Yes, you would start with a low dose of 10 milligram twice a day and increase the dose gradually. The maximum dose which I would use in Indian patients would be 40 milligram twice a day. And the American doses are definitely higher. And you should be careful that the patient does not have any history of asthma. The patient does not have any peripheral vascular disease, no suggestion of depression in the patient. And preferably, if the patient is a young male patient, I would try and stay away from propranolol in that patient. Now, would you use it with flunarizine? Yes, it can be used. I am not in favor of using it as a combined treatment in one tablet. I would always go with separate usage of flunarizine in addition, because then I know which drug has what side effects. And so if there is some excessive sedation, I know what has caused the sedation. So therefore, I would use it that way, and a very small dose of flunarizine of 5 milligram to start with, to increase to 10 milligram later on. So these are the situations in which, and propranolol is a good drug to start with in a patient who doesn't have the contraindications.
Right. So you are saying that you will not prefer a fixed dose combination, but you would use the drug separately.
Yes.
So that you can titrate and see that if any of these are causing more problems than the effects. Okay. Now, Dr. Banerjee, can steroids be useful in migraine? And if so, how long they should be given?
Unmute, sir. Unmute the mic, sir.
Thank you.
Yes.
Am I audible now? Yeah. Okay.
Yeah.
Steroid, if it's a chronic migraine, if it's attained a situation where the migraine is persistent and other, or it may be with superimposed medication overuse headache, in those cases, I use steroids. In medication overuse headache, the first thing is to discontinue the analgesic, the offending analgesic totally. And in these situations, I give steroid to the person, and I still give steroid at the dose of 1 milligram per kg body weight. And initial stage, I tend to hospitalize the patient for a few days, because these people have a tremendous tendency of taking on painkiller whenever they have this pain. So I think the way of hospitalizing them is to ensure that they don't take painkillers. And I keep them on steroids, and gradually.
So how long do you give? How long do you give?
It depends. I've given them for say 7-10 days, but in certain situation I've even continued for a month in a tapering dose. That sort of situation. Another situation where I give steroid is when there's a status migrainosus, a very severe intense headache which continued for over 72 hours. I have to give them steroids, hospitalize them, give them steroids, along with rehydration measures and other medicines. Okay.
Sanjay, this is a question for you. What are the drugs you can use during pregnancy and lactation?
Usually, sir, in pregnancy, there are not many drugs which you can use, but as an abortive therapy, we usually give a paracetamol, and in some cases, even sumatriptan can be given. So I prefer to start this drug as far as preventive measure.
No, but if the patient is not responding, and then still you need to give some preventive treatment, so what drug will you then give?
Usually in my case, I will first of all advise the lifestyle modification, because it's very important in especially pregnancy case. And there are so many comorbid conditions in pregnancy. Definitely you should deal with that. Maybe some vitamins deficiency, maybe they may cause. But I personally prefers to start a low dose of some antidepressant, maybe some like dothiapine, like I prefer personally.
Dr. Ravi Shankar, what's your plan for pregnancy? The
I
prevention?
would go with amitriptyline and propranolol, and if the attacks are very frequent, I would go in with an occipital nerve block also. And in some situations, oxygen also helps in migraine, particularly if there are some autonomic features.
Actually, that has proven to be very good in pregnancy because there is only a superficial injection and it doesn't cause a systemic side effect. Yeah. And although it is to be said that in pregnancy, about 2/3 of the patients will have a very decreased, incidence of migraine. So you need not bother much, but about 1/3 may have a same frequency, or in at least a small percentage of them may have an increased frequency. Now, this is for Thomas. Thomas, they are asking, someone is asking about what's your take on Botox in chronic migraine, and if at all you give, how long will you continue?
Botox is a very nice option for migraine if they can afford. Only thing with Botox is the money. Otherwise, it is a very nice concept. And when patient has chronic headache and medication overuse, and they're not ready to wait for stopping the medication overuse headache, it's nice to give Botox. I have used a lot of Botox, especially for migraineurs, and 150 unit you space over the frontalis, temporalis, occipitalis, then the neck muscles, and people do well only if you give the medicine. But only thing, because of the cost, main problem is the cost. Maximum I have injected will be 3 times, but most of the people, when you give the first injection, they come out of that medication overuse headache, and by the time you start another drug, you can give amitriptyline, you can give metoprolol, you may give topiramate. So by the time these medicines work, so as Sanjay and Dr. Ravi Shankar suggested, give the proper lifestyle modification, avoid the medication overuse, and give the time for migraine medications. Most important thing is patient expects an immediate recovery with the prophylactic medicines, which usually doesn't happen.
So in your case, you are suggesting that you use more as a transitional prophylaxis rather than a continuous prophylaxis.
Absolutely.
Okay, right. Okay. Now this question is for Dr. Amit Shankar Singh, that what is the use of acupuncture or acupressure in recurrent migraine headaches?
So, sir, this is a experimental therapy, I think, and occipital nerve block, Botox, they have a specific role in migraine prophylaxis. So I'm not much aware of the role of acupuncture, acupressure in migraine.
Yeah. So, Dr. Ravi Shankar, any comments on that?
There are studies from Germany which talk of a lot of acupuncture for migraine also.
Even China also.
Yeah, but traditional Chinese medicine and acupuncture are very common in China. But here in India, I don't think that even acupuncturists treat migraine. They go more for back pain and neck pain rather than migraine. So I don't think that there is.
Right. So it is, acupressure is useless. Acupuncture may have some role. There has been one systematic analysis in which it found that it may be helpful, but there is not much clear-cut evidence for that. And as Dr. Ravi Shankar said, in India it's difficult, the practitioners of acupuncture are there, but they probably don't know much about a migraine. So it's a difficult situation. So another question is for Dr. Ravi Shankar, and this is interesting. Somebody says, okay, migraine, why do you treat? I mean, these are often, very benign conditions, and they go off over after some time. So I think Dr. Ravi Shankar will become jobless. He says, what is the need for the treatment? I mean, most of his migraines over time they become better.
I always say that the migraine you see and the migraine we see are entirely two different things. When you speak and make a sentence saying that, why do you need to treat migraine? And it obviously means that you have not understood the misery that migraine can cause. And when you practice in a tertiary clinic and you see some of the courts of misery, as I call it, of patients who are on the verge of suicide also, and they have taken so much of medication and nothing has happened. They've changed ambitions, they've changed careers, they've given up medical seats, and they have left their job in the Gulf and come back to India. These are sentences which touch you and make you feel that after all, someone has to treat. And you yourself fail in 30% of scenarios. I mean, it's not that even in the best of settings, you find 30 to 40% migraines cannot be completely treated. So it is such a difficult condition to treat, and the misery and disability are so huge that is why I put up the first slide where I talked about the painful truth, where there was a collaboration between WFN and IHS. Surely they would not be doing it unless there was such a reason to do it. And now, as Debashish pointed out, so much of pathophysiology has been unraveled in the last 20 years. So all that pathophysiology comes to zero? Cannot be so.
Okay, right. And also I will add that, there are now quite a few longitudinal studies which are there, which have, followed up migraine patients for 30 years or 40 years. Like there is a Swiss study, there is one study by another author which studied for 30 years. And even after 30 years, they have found that about 25 to 30% of the patients still keep on having significant migraine headaches, despite everything. So migraine is a chronic disorder, although its manifestations are episodic in most of the people, but in neurobiology, from neurobiology point of view, it's a chronic disorder. So always don't think that, and we say usually, oh, you go 40, 50, your headaches will go off. You come to my clinic or Dr. Ravi Shankar's clinic, you'll see plenty of men and women who are coming after 50 with a continuation of their headaches, migraine, and say they're severely disabled. So it's a disabling condition, and that's why the Lancet study has said that it is the second commonest disabling condition in the world. So it's not that it's going to go away. Now, another question that I would like to take, they said currently it's 1,225 delegates who are attending this symposium. 1,225 delegates who are attending this webinar now. And they're saying that, just like migraine, most psychiatric illnesses are neurobiological. So now I think there is an important distinction to be made here. Now, migraine is a brain disease. It's not a psychiatric disease, right? In this, obviously, there is a biological correlate in migraine. It's a brain-driven disorder, right? And many of the psychiatric disorders are also brain-driven. So just because the distinction between neurology and psychiatry is an artificial one. Because just because the technology has not yet improved to such an extent that we can actually define the abnormalities in a psychiatric patient, what are the metabolites that are different, what are the neurotransmitters, we cannot image that. It is slowly coming up. I mean, those imagings are coming up, but soon this distinction will go off. So therefore you have to remember that migraine, but it is not that just the migraine is a result of depression or anxiety. These are the conditions which are comorbid with migraine. That means they are occurring at a more frequency than the rest of the general population. So you cannot say that migraine is due to depression or migraine is due to anxiety. So this distinction is very, very important. Of course, if there is a significant depression or anxiety, you need to actually treat that along with the treatment of migraine, and that will yield rich evidence. So carrying on with your lecture, they are saying that, can you say that how much is the effectiveness of the scam treatments in migraine? I mean, are they important in prophylaxis from your point of view? Dr. Ravi Shankar.
Yeah. Now, definitely they are important. First is, since you're always combining them with some amount of pharmacotherapy, it is difficult to quantify. But we have seen a lot of patients who were on pure pharmacotherapy when they came to us, and we added alternative treatments. We told them to go in for some non-pharmacological methods, and we sent them to psychologists for cognitive behavioral therapy, and we started them on yoga. We found that there was a definite improvement. So you cannot quantify it, but overall, you can say that adding these treatments will definitely help in some of your refractory patients. So it might be even control of lifestyle measures. They also, chronobiology, you tell them to do the same thing at the same time every day, you find that that also sets the people on track. So it is not quantifiable, but it's definitely helpful.
Right. So I think we have covered most of the questions. One or two are left. We'll take it later. Now I request Dr. Sanjay Prakash to kindly load your presentation, share the screen, and start with your case. Dr. Sanjay, please.
Yes, sir.
Dr. Sanjay Prakash is the professor and head of the Department of Neurology at Baroda and he has been very active in the headache field, and he has got very large number of publications on patients with headache. So Dr. Sanjay is going to present a good case and very interesting case, which will be useful for all of you. Dr. Sanjay Prakash, please.
Yes, sir. Am I audible? Hello?
Yeah, you're audible. Right. Okay, start.
Okay, good evening, everyone. And thanks, Dr. Devasi, sir, for giving me this opportunity to share my case experience here. I am discussing a simple case, just a exertional headache, but I will like to give some take-home message in this case. This is the case. I'm sorry, it is not working.
Sanjay, move your mouse. Move your mouse. Move your mouse and see.
Do a slideshow, otherwise it will not come.
Slideshow and move your mouse. Go to slideshow and move your mouse and see. Now it's working.
Sanjay?
Not working, sir. Video is not working.
I think you can do the stop sharing first, and then you click the start sharing, share screen, and on the lower side you see that there is a button for audio. On the left hand side, lower side of the screen.
Audio.
You click that, tick that, audio, and then start presenting. Did you get it?
No, sir, I didn't find it. Audio.
Lower down and the left hand lower side of the screen.
Yeah, sir, is a top bottom left side is share computer audio.
Yeah, the computer, I have shared that.
Yeah, share screen.
Now
before the share screen option.
Share screen.
Sanjay.
Yes, sir.
You stop share.
Yes, sir. Yes,
now you share screen. Now click on share screen. Before that, there is an icon there on the lower side saying share computer audio.
Share computer sign optimize screen sharing video. I have two options.
Yeah, two options. Audio. Yeah, share computer sound. You can click on
sound.
Yeah.
I have clicked that, but it is not.
Now you share. Now you do the screen share. I mean screen to a full screen.
I am sorry, sir. Just I will read out this case.
Yeah, you then continue with the case.
Yes, sir. This 66-year-old man is a smoker. Am I audible now? Having recurring headache for last 2 years, but headache was just after walking for a certain hour, and all attacks were on exertion only. Initially, patient used to have headache after walking for 10 to 20 minutes, but gradually this distance and time period gradually reduced. And when he came to our OPT, there was a headache attack just after walking for just 1 minute. The headache used to start on the occipital area and just spread out rapidly, just in a few seconds to few minutes in anterior part. Headache used to be severe to very severe, and patient can't continue walking, and patient have to stop walking. And headache used to get relieved after 30 minutes rest, and patient after that completely symptom free. And again, patient can have headache after walking for again certain minutes. But there was no associated chest abnormality, abdominal discomfort during the headache attack. Occasionally he felt nausea, and there was no any other associated symptom. Physical examination did not reveal anything, and neuroimaging was normal, and ECG demonstrated old myocardial infarct, but patient was not aware of that he had myocardial infarction in the past. So it was the silent myocardial infarction. So we suspected a possibility of cardiac related event, and cardiac cephalalgia was suspected, and we asked to patient to take sublingual nitrate after walk, just in my OPD. And after walking for 15 to 20 minutes, he had an attack, and we asked to take sublingual nitrate, and he had marked relief just in 1 minute. Again, this video will not work. So just he here describing the effect of sublingual nitrate, and there was the response in just 1 to 2 minutes. So sublingual nitrate provided complete relief within a minute, and we investigated this patient on the line of the cardiac cephalalgia. Definitely MRI was also done in later on, but stress test was done. ECG demonstrated ST depression in the inferior leads, and there was a similar headache during the state test, but there was no cardiac symptom or any abdominal discomfort at that time. Again, at that time during the stress test, patient again responded to sublingual nitrate. Coronary angiography was done, and it demonstrated 3 vessels disease. So there was 3 vessels disease. We suspected a coronary artery disease, and patient was suggested for bypass surgery, and he went for them. And there was complete relief in the symptom, and we followed the patient for at least 12 months, and there was no exertional headache after the coronary bypass surgery. And we reported this case as a cardiac cephalalgia. So this is a simple case, especially if you know the case, if you are aware of the case, you can make a diagnosis, but it may be the life-threatening condition. So I will discuss some literature, whatever is written in the literature regarding the cardiac cephalalgia. So some part regarding the review of the literature of the cardiac cephalalgia. We all know coronary heart disease, in the coronary artery disease in angina or myocardial infarction. Pain starts in the retroesternal area, but it may radiate to jaw, neck, upper limb, back, and abdomen. And rarely, these all area may have isolated symptom without having much symptom in the retroesternal part. So isolated jaw pain, isolated neck pain, isolated upper limb, back pain, epigastric pain are known in case of the coronary artery disease. But what about the headache? So there is one or two studies, they have demonstrated about 6% patient with myocardial infarction or angina may have chest pain, a headache. But what about the isolated chest pain? There is very few case report. There is no epidemiological data, but there are some cases reported. And in literature review, we noted about more than 45 cases of the cardiac cephalalgia. So just review these 45 cases. We noted following things. Mean age was 62.5 years, mainly elderly patient were there in this group, but it was noted in the youngest age was the 35 years patient. Risk factor is very important in such type of patient. You can see here there are 5 different type of risk factor: hypertension, hyperlipidemia, smoker, diabetes, and family history of the myocardial infarction. And at least one symptom were present in all reported cases: hypertension, hyperlipidemia, smoker, diabetes, and family history. So risk factor is very important in such groups. Site is not very specific in the literature review. It may involve anywhere, even it may be unilateral, but it is always severe and excruciating type, and character may be just like migraine throbbing, but occasionally non-throbbing case report have been also reported. Frequency, if it is the first attack of the myocardial infarction, that may be the first severe headache attack, but it is just because of the angina. Patient may have many attacks in a day for several months or even for years. Duration, highly variables. In our cases, patient had attack for 15 to 30 minutes, but reports are there in the literature for few minutes to few days. So may have whole days, just like a migraine headache. Relation with exertion, classically it is described in relation with exertion, but even mild physical activity may cause, just like a migraine headache. In migraine headache, we all know some routine activity may cause aggravation of the headache. So just like in migraine, in that here patient may have exertional headache, and but 30 to 50% patient had headache even at the rest. We see the associated, if we review the associated feature during the headache attack, cardiac cephalgia headache as a sole presentation was noted in 50% patient, and other 50% had some other symptom such as mild chest, arm pain, and epigastric distress was noted in the 50% patient. Nausea and vomiting was reported in up to 45% patient, and photophobia and phonophobia was noted in 20% of the patient. As far as the investigation is concerned, pathological abnormality was noted in the ECG in 57% patient. It's the baseline investigation. Baseline ECG shows abnormality in every alternate patient. ST segment elevation was main feature, and T wave inversion was also noted. A stress testing was done in 2/3 of all these cases, and headache was reproduced, and it was associated with the ECG changes. Cardiac enzyme was done in a few cases, and it was elevated in few cases. Coronary angiogram was done in 2/3 of cases, and all showed at least moderate to severe coronary artery disease. As far as medical management is concerned, these all 4 cases, some were treated as a medical therapy and some as a endovascular therapy, and both were effective in all these 45 cases. Now we will review the cardiac cephalgia according to the criteria, ICSD-3 criteria. There should be headache, there should be evidence of myocardial ischemia, and you will have to find the evidence of causation. And they have provided, just you need 2 of the following. They have provided 4 points to establish the causation. First is the headache should be in temporal relation to the onset of acute myocardial ischemia, and that headache should aggravate or resolve with the ischemia. They have provided 2 points here. Headache worsened in parallel with worsening of the myocardial ischemia, or headache improved or resolved in parallel with the improvement of ischemia. And they have provided 4 characters in the C group: moderate to severe, nausea, no photophobia, phonophobia, and aggravation by exertion, and 2 of these 4 should be there. And last one is the relieved of the nitroglycerin and its derivative. So to find a causation between the headache and myocardial ischemia, they have 4 points, and these out of 4, 2 should be there. Here I would like to compare with the cardiac cephalgia with the migraine. So one side, on left side is the migraine criteria. On right side, I will compare with the cardiac cephalgia. 5 attacks in the migraine with without aura. So if it is first attack of myocardial infarction, there will be just 1 attack. But if it is because of the angina-like attack, there will be definitely 5 attack. Attack 4 to 72 hours. In our case, it was the 30 minutes, but 4 to 72 hours attack of the migraine, maybe with even with the cardiac cephalgia patient. And in third group is the NE2. Usually it is the bilateral or holocephalic, but few case report have unilateral headache even in the cardiac cephalgia. Throbbing is noted, moderate to severe attack is there, and aggravation by or causing avoidance of routine physical activity of the migraine is the one of the important characteristic feature, and definitely this is the important characteristic feature of the cardiac cephalgia. Nausea is in the criteria of the cardiac cephalgia, and few percent, up to 20% patient may have even photophobia and phonophobia. So there is some similarity in the migraine with the cardiac cephalgia. And if you see the other side, there is also there's a migraine patient may have chest pain, and here headache will be more severe, even chest pain may be more severe. So migraine may cause chest-like symptoms that may mimic coronary artery syndromes. So diagnosis of cardiac cephalgia is very important because it's the life-threatening condition. And another important point here is that if it is you are suspecting a migraine in cardiac cephalgia patient, you may start triptan, and triptan may aggravate the coronary artery disease. So it is very important to differentiate cardiac cephalgia or migraine in, especially in the elderly patient. So if we summarize, or it is as a take-home message, any elderly patient having risk for vascular disease, we have mentioned at least 5 risk factors there, and develop new onset migraine-like headache, severe attack, throbbing, aggravation by exertion, nausea, vomiting there. If nausea, vomiting there, think of the cardiac cephalgia, even base like ECG may be abnormality. So such patient can be subjected to ECG, stress test, even coronary angiogram. Thank you. I am sorry video didn't work.
Right. Sanjay, that's a very beautiful case actually, and this is an uncommon, condition which can often be missed until unless one is aware of it. And only a handful of cases have been actually, published in the literature. So, but this is a thing which one should remember that, the cardiac manifestations can be the presenting feature of a particular headache syndrome. So that's a important thing to remember. Dr. Banerjee, would you like to comment on this a little bit?
Yeah, I mean, this is a very interesting observation and a very interesting case. I mean, I read on the literature, but I can't recall of seeing any such case. Uh, it's a very interesting case, and one should keep that in mind. The differential.
And Dr. Ravi Shankar, how many have you seen some cases?
I have seen 2 patients with cardiac cephalalgia over a period of 25 years. And the presentations were straightforward and simple. And here, Sanjay has taken it one step further by giving us all the literature on the presentation. So I think he's analyzed it quite well. So this is worth remembering in elderly people who come with headache on exertion. So if it's straightforward, it's easy. Otherwise, it's difficult.
Right, right. So one question for you from your leftover question from your last lecture, what should one prescribe as a preventive management for geriatric patient presented with migraine comorbid with diabetes and hypertension?
Comorbid with diabetes and hypertension. Okay. There is no contraindication to starting with, because of diabetes, I won't start with beta blockers straight away, although there is no real contraindication, you can still start. But I would go with a 5 milligram dose of flunarizine and increase it to 10 milligrams if there is no depression. And over a period of time, I would add divalproex to the regime if there is no, because at this age group, there are hardly any contraindications that is likely to be there for divalproex. So only weight gain with both these drugs would be there. So I would still go with propranolol and divalproex, and the stroke propranolol, stroke flunarizine, and divalproex would be the option.
Okay, and this is for Thomas Matthew. I think he will like this question. Is there any role of aromatherapy in migraine prevention?
I was expecting something like that. Last you gave.
You see that in India, there are 2 oil barons. One is Ambani and another second is Thomas Matthew. He is deeply interested in oil business, right? So he is going to talk about aromatherapy.
Sir, the most interesting thing is most of our patients, they use Vicks, Amardagel and Chadubam as acute therapy. So that is very common. And we did a study, and big studies are coming. We need time. Now, Corona people have stopped coming to the OPD with small complaints of headache. So this aroma thing, it's very interesting. And many people tell that it relieves, and many doctors use it. They put Vicks, Amardagel, they feel happy. Their headache relieves. So we found that around 16% of people, it improves. Around remaining around 30-40% felt there is no improvement, either not better, not worse. But few people felt they worsen. So I think there is a variable effect on acute headaches with these aromatherapies. But on chronic therapy, you may have 2 things. So somebody is having a chronic headache, then it may add to a medication overuse headache. So there is a very subtle line between substance use headache and medication overuse headache. When you say medication overuse headache, it has to be effective for migraine, acute migraine. Then only we can say it a medication. So I am still little not fully clear, though. Our first paper we published on Amardagel in a child who was on 4 to 5 anti-migraine drugs. He came, I was about to give Botox, then I identified that he was on a chronic Amardagel for 1 year. Then I stopped Amardagel, his headache improved in 2 weeks. So in medication overuse headache, you stop the medication, headache improves 80%, improves 70 to 80% in 2 weeks. In substance causing headache, it improves in 3 days time, the substance use. So before big randomized studies and other things come, I think all the clinicians I request, please check what alternative medicines our patients are taking, because they might have an implication on your treatment. So along with all your questions and NSAID abuse, please ask what you do for headache. So most of them will come and tell, sir, we use axe oil, we use Amritanjan, we use Vicks, and you just stop it, give a headache diary. It's very simple for a clinician. Just give a headache diary. Before doing any major interventions or tablets, you can just request the patient, can you just stop these items you are using, and then keep a headache diary. If you are correct, in 2 weeks, you'll know that there is a significant improvement in headache. And the latest thing I've told many meetings, toothpaste which contain camphor and eucalyptus from Dabur Red, Colgate, Veda Shakti, then Ayush Liver, most of them contain camphor and eucalyptus in Patanjali, Dantakanti, so many are there. So just tell them, if you're using any of these products which contain that, just stop for 2 weeks. Just stop for 2 weeks and see the headache diary. And then many patients, I'm telling you, it's a remarkable discovery for people who manage migraineurs, because as Ravi Shankar sir has really found, it's difficult to manage. When a chronic migraine patient walks to your clinic and tells, I've met 4 doctors before and already is on valproate and topiramate, it is a pain to see such patients because you can't offer much.
Okay,
Yes.
okay, got your point. So I think people who are listening, they will take a clue from that. So I think we have covered all the questions except the last question to Dr. Ravi Shankar. Any role of TTDS or TENS in migraine? Transcutaneous stimulation in migraine.
It is mentioned as one of the physical therapies which definitely help in people who have migraine with tension type headache, but I personally have not had any experience, so I don't think I'll be able to comment on that through direct personal experience, but it is definitely, there are studies which include TENS as one form of additional therapy in the physical therapies.
Correct. So I think we have had a good discussion about the migraine pathophysiology, management, the variants, and some beautiful cases by our esteemed panel. And I'm happy to tell you that we had finally 1255 persons, participants who have joined this webinar. So I thank them for taking out the time and joining, because in this webinar time, everywhere the webinars are happening, and so still you could manage to come here and join us. And a very important subject like migraine, which has not been given due importance for a long time in our country, which is now picking up. Now more youngsters, like Thomas Matthew, Amit, Sanjay, they are picking it up and making it go ahead. So I think the future is good, and I think that if you treat headache patients effectively, you give them the maximum benefit and the patients stick to you. So if you treat headache patients well, your practice is going to grow, right? So that is the incentive for studying headache medicine. Absolutely. So with that words, I'm thankful to Asian Society for conducting this meeting, and also the sponsors who are there who have helped us to organizing this meeting. And I think overall we had a fantastic time, and I thank all of you for agreeing to participate, and I hope that we carry on with this work in future, and we'll get your support in future too. So stay safe and take all the precautions during this COVID times. They're difficult times, and you must stay safe and take all the precautions. So with these words, Namaskar, Shivratri, good night.
Thank you all. Bye.
Thank you, sir. Thank you, Devashish sir.
Thank you. Nice to see you.
Thank you, Devashish. Thank you all. Bye, Tapas.
Thank you.
Bye, Amit.
Good night. Take care.
Thanks, Thomas. Thank you.
Bye, Thomas.
Thank you, sir. Thank you, sir.
Sanjay.
Thank you, Ravi Shankar sir. Thank you.
Thank you. Chaital, you can stop the live. Thomas sir, good night, sir.
Yes, sir. Good night. Thank you.
Good night, sir. Yeah. Yes, sir.
Thank you,
sir. Thank you very much, sir.
Thank you.
Good night.
Thank you very much. Thank you.
Thank you very much, sir. Amit sir. Thank you. Good night.
Thank you.
सर 12:56 पे पहुंचे हैं.
It's a wonderful, sir.
10 मिनट में मैंने आपको 12 स्क्रीनशॉट भेजे. 5 मिनट में चेंज हो जाता है. मैं 12:44 बोलता हूँ, 12:46 हो जाता है इतने के टाइम पे.
अच्छा हुआ.
नहीं, बट अच्छा है सर. एवरीवन लाइक बहुत अच्छा है. लोगों ने मतलब जो जहाँ से भी आया वो लॉग आउट नहीं हुआ. उन्होंने पूरा देखा है लोगों ने. अच्छा है.
वेरी गुड. तो एक काम करो राहुल.
हाँ सर.
एपिक्वेस को बॉडी में चिपका दो और
ये वाला भी बॉडी में चिपका दो. Monday I will start emailing to both.
हाँ हाँ सर
बाकी है मेरे को मेल करने.
और रीजन वाइज तोड़ना पड़ेगा ना सर, रीजन वाइज तोड़ देंगे इसको.
नहीं नहीं डायरेक्ट वो बीसीसी में डाल देगा माइकल सर.
ओके
मंडे सर आई विल गिव यू मॉर्निंग में, ठीक है ना?
Monday.
ओके ओके ठीक है साहू साहब. ओके गुड नाइट.
थैंक यू सो मच. थैंक यू माइकल सर. गुड नाइट सर.
थैंक यू सर. चलो साहू साहब बाय बाय. चलो.